Hello, everyone. I hope everyone is having a good day or a great evening. Welcome back to our interactive nclex-rn review session. And we are on day 29 of the 90-day free NCLEX review sessions with us. So we really want to invite you to enroll in our dynamic NCLEX review course at Stancoast NCLEX Coaching for personalized support. And you can access our 3,000 NCLEX-style questions and 10 hours of animated videos for flexible study. And you can gain confidence with our on-demand video library and also the practice exams. So we really want you to learn more and hope you can engage with us at www.stancoastnclexcoaching.com. And so for more information, visit the link below in our description box. And the feedback from you matters. So kindly share your thoughts or questions in the comments, and we'll be happy to assist you. Now, today we'll be doing the third part of our NCLEX questions about all the respiratory concepts. So let's get started. Now, we have our next question over here. And the question states, a patient with a long-standing cough is scheduled for a bronchoscopy with biopsy. What should the nurse do immediately after the procedure? Again, rereading the question. A patient with a long-standing cough is scheduled for a bronchoscopy with biopsy. What should the nurse do immediately after the procedure? Is it A, encourage the patient to consume clear liquids? B, instruct the patient to remain in bed rest for at least 4 hours? C, maintain the patient NPO until the gag reflex returns? And D, keep the head of the bed elevated at 90 degrees. So we have those options. This is a multiple choice type of question. And the scenario is talking about a patient scheduled for a bronchoscopy with biopsy. And it's asking us, what should you do? Or what should the nurse do immediately after the procedure? So you have the following options again. A, encourage the patient to consume clear liquids. B, instruct the patient to remain on bed rest for at least 4 hours. And C, maintain the patient NPO until the gag reflex returns. And D, keep the head of the bed elevated at 90 degrees. Now, you can put your answers in the comment section or also in the chat box, so we will see who's participating. And kindly let us know as well where you're from, maybe from the US, any of the 50 states, or from overseas. All right, we're seeing some answers here from Ernest. Oh, not Ernest. Yeah, welcome, Ernest. We have Mary and Linley. We have Patience. Letter C. Okay, let's find out, guys. Well, that is the correct answer. So let me mark that one. Letter C. That is to maintain the patient NPO until the gag reflex returns. That is your role here as the nurse taking care of this patient immediately when they return from the bronchoscopy procedure. Okay, and the reason for that, it's because the patient is going to have an anesthetic agent that is going to suppress the gag and also the cough reflexes in order to facilitate the procedure. Again, the reason why the gag reflex will be needed to be monitored by the nurse once the patient returns to the nursing unit, it's because the patient before the procedure, they're going to receive the anesthetic agent. And the reason for that is to suppress the gag reflex in order that the medical provider will be able to conduct the procedure safely. Okay, so let me write that down. Welcome, Rodeline. We have Pauline, Sefort, and from Orlando. Okay, this is the first time I've seen your name pop up. And we have Jennifer from UK. Welcome to the classroom. All right, so that is because the patient is getting a anesthetic agent, right? And the reason for that is to diminish or decrease the gag reflex. Why it's not letting me write that word. So the reason for that is to facilitate, in order for the doctor to perform the procedure, then the gag reflex need to be diminished using that anesthetic agent. Okay. So what's going on here? Increase the gag reflex. So once the patient comes back from the procedure, make sure that you're not gonna introduce anything by mouth, no water, no food at all, because they're gonna end up with choking with that kind of fluid, and potentially they're gonna aspirate from that kind of water content or fluids or whatever it is. So no medications, let's say oral medications, to be given before the patient is cleared to be safe in taking that PO medication. Now, the other answer is here, letter A. That's incorrect because we're not supposed to be giving them anything by mouth up until our patient is cleared, that they're able to swallow anything. So make sure that we have to test the gag reflex using that tongue depressor. Check if they have that gag reflex, okay, before you put anything in their mouth. Now, also with letter B, instruct the patient to remain on bed rest for at least 4 hours. Well, that is an overkill right there. There is no requirement for this patient to stay in bed for at least 4 hours. It's not necessary unless there is maybe a complication or a patient may need it. But with this scenario, we don't have that kind of information. So bed rest times 4 hours after the procedure is not required. So eliminate that unnecessary intervention. Now, if we're going to answer letter D, keep the head of the bed elevated at 90 degrees, that simply means that the patient will be sitting upright. And it is not necessary for this patient to maintain this position after the bronchoscopy unless it is specified by the medical provider. Okay? So our goal here is to make sure that we are keeping the patient safe. After the procedure has been completed, we want to make sure that we are protecting the patient's airway. Okay, let me do this. All right, so we want to make sure that our patient's airway is maintained. So there should be patency of their airway. And you can also check the gag reflex other than using that tongue depressor or tongue blade. You can also ask them if they can at least produce some saliva and they can swallow it. That's another one. But that is something that we don't normally recommend, but that is something that you can do on top of the gag reflex check. All right. You should be doing the gag reflex checks before they start swallowing anything, even their saliva. So like I said, it's only a secondary technique that you can do as well. All right. Now let's move on to the next question here. Question 15. What assessment finding indicates that the nurse should take immediate action for an elderly patient? Okay. Again, the question states, what assessment finding indicates that the nurse should take immediate action for an elderly patient? Is it A, ineffective cough effort, B, rounded chest shape, or C, dry mucous membranes, and D, crackling sounds in the lower lung fields? Well, we have Lucy Jewel from Miami, we have Ernest from Indiana, and Suzette, welcome to the class. So again, the situation or the scenario states, what assessment finding indicates that the nurse should take immediate action for an elderly patient? Is it an A, ineffective cough effort, B, rounded chest shape, C, dry mucous membranes, and D, crackling sounds in the lower lung fields? All right, I'm seeing virtual Virtuous Lady answering D. Obey, welcome back. All right. Mary, welcome back. Lucy answering D. Marie Floor answering D. Patience answering D as well. Pauline, D. Joyce, and Suzette. Very good. Hello, everyone. Rodeline. All right, very good. So that is the correct answer here. Why? Especially when we are talking about an elderly person here, because with the aging process, there's so many things that can set into the body. The body will deteriorate. There will be bodily changes that can take place whenever the person will age. Okay. If we are going to answer letter A, ineffective cough effort. So let's start with that option, letter A. Why is letter A? Is it a correct answer or is it a wrong answer? Well, we'll identify right now. Letter A is actually a wrong answer. Why? The reason for that is because older adults commonly have weaker coughs due to the age-related changes, and this will require monitoring, but do not necessarily gonna need immediate action. All right, so let me write that down here. Okay. Does not need immediate action. Let me try my pen. Oops, why is it going to the next slide? Anyway, let me try that one more time. Does not need immediate action. This is a chronic issue that will develop over time. And so you will not be able to really address that ineffective cough effort in this situation. All right. Immediate does not need immediate action. Oh boy. Yeah, let me try my pen again because it's kind of doing so many weird things right now. Wait. Why is it transforming into a eraser? Oh boy. Nope. Why is that doing that? Okay, does not need immediate action. Now for letter B, rounded chest shape. So that basically is similar to the barrel chesting, okay? So this is something that can develop over time, especially in the patient has an emphysema, a COPD, all right? So your letter B is also going to be eliminated at this point, and this is commonly seen in the elderly individuals that may have the COPD, all right? Does it need immediate action right now? No, it doesn't. It is a chronic thing that will happen over time. And so it doesn't change. The rib cage size doesn't change overnight. It takes years because of the inflation, the hyperinflation of the alveoli, and there's nothing you can do about it in the immediate phase. All right. So how about letter C, dry mucous membranes? Well, this is a selection we're in. It's also common in the elderly population, and this will probably require hydration strategies. However, it doesn't really indicate an immediate action. So we are left with letter D. So don't forget about the elimination process, guys. Do not look immediately for the correct answer. So what is the crackling sounds basically? This is what we call as the coarse crackles. And this basically represents that the patient is having fluid accumulation, okay? There is now fluid that is consolidating in the alveoli, and it could be possibly related to a heart failure, or a heart failure that may be right-sided as a result to a pulmonary hypertension, or it could be a heart failure on the left side of the heart, which is basically a complication of other cardiac disorders, let's say MI, that has been going on for quite some time. And so we are gonna pick this one. This basically represent that the patient might have a congestive heart failure with that fluid accumulation. I'm going to try again. Wish me luck. Oh boy, why is this? Okay. Fluid accumulation could be related to right-sided heart failure, secondary to pulmonary hypertension. Whoops, it's transitioning to the second page. Let me just write down here. Secondary to pulmonary hypertension. Or it could be a left-sided heart failure that has been going on for quite some time. And so if there is, let's say, an exacerbation of the congestive heart failure on the left side, it could be aggravated by maybe overload of the fluid, maybe an inadvertent administration of IV fluids, or let's say faster rate in the administration of blood products that can lead to the fluid accumulation as well. Okay, now don't forget to remember the different manifestations, especially with the right-sided or left-sided heart failure. Most often, this can result into congestion of the lung fields, the accumulation of fluids into the alveoli. All right. Now, let's move on to the next question here, guys. Number 16. What is this? A nurse is assessing a patient admitted with chronic obstructive pulmonary disease who has experienced worsening shortness of breath over the past 3 days. What findings should the nurse prioritize reporting to the healthcare provider? Okay, let me reread the question. A nurse is assessing a patient admitted with chronic obstructive pulmonary disease who has experienced worsening shortness of breath over the past 3 days. What findings should the nurse prioritize reporting to the healthcare provider? Is it A, respiratory rate is 38 breaths per minute, or B, chest shape is equally wide from front to back, or C, both lungs show reduced expansion, and D, percussion produces an unusually resonant sound? All right, take your pick. Okay, let me see. We have Shruti Delipu, is that how you say your name? And we have Anago Shenenye from Ontario. Good morning, NJ. Is it NJ Nancy? We have Chichi Idwin. Welcome. Roberta. All right. Good vibes. Answered letter D. So take a look into the situation right now. A patient has a COPD, and there is a worsening of the shortness of breath over the past 3 days. So which of the manifestations you should prioritize reporting? Okay, don't forget the vital signs of your patient. You gotta screen your answers, your answer rather. You have to capture that abnormal assessment finding. Well, of course, you are seeing a majority of the options here are abnormal, but you gotta find for that option that is going to be really critical at this point. All right. So I'm seeing a whole lot of D's. Only one answered. Obey answered A. We have also Lin Lee answered A. We have Mary answering letter A. Okay. Well, we'll reveal the answer right now. What is letter A here? Respiratory rate of 38 breaths per minute. Okay. That is unusually high, right? That is tachypnea. Don't forget your basic nursing assessment. Okay, have mercy on me right now because I'm really trying my best using this pen. So that is tachypnea. That is abnormally high respiratory rate. And this is a critical indicator that the patient is in respiratory distress. Okay. Guys, this is way high. If I am the nurse taking care of this patient, and this probably would be my first time seeing this patient as a new assignment, probably I would be flying in the room right now. If I am not aware, if I'm not given a verbal report of what the diagnosis is. Let's say, for example, I'm just like one of the team leaders rounding the patient's room, and all of a sudden I'm seeing this patient with 38 breaths per minute. It's not a good assessment finding, guys. You gotta pick that one. It is a critical indicator that the patient has respiratory distress. Okay, as I've always mentioned when we started the discussion about respiratory concepts, you gotta really pay attention into the normal range of your respirations. Okay, especially for the adults, our range normally is set at about like 14 to about 20 cycles per minute. Okay, that is the normal range for the adult. So if there is, let's say, anything above that, let me rewrite that because this is on the bottom. Anything above 20, even a slight increase in the patient's respiratory rate, that will actually cause some concern already. And that will require much more of monitoring. Make sure that you are really paying attention to the change in their respiratory rate, because it could mean something, guys. It could be a signal that your patient is probably not getting enough O2. And this is your body's response to a decrease in the delivery of oxygen to the body tissues. Okay, so that is the reason why we are answering letter A this time. Okay, so basically the patient is really struggling to maintain adequate O2, and definitely we need to address this issue. We gotta intervene that by giving them oxygen therapy. Okay, and this would be one of the interventions that we should be doing. We're going to have to put them in the 90 degrees angle. We have to sit them upright in order to facilitate the expansion of the lungs. This would be one of the nursing interventions, the first nursing interventions that you're going to do. Sit them up. If there's no contraindications, you can do that in order to facilitate maximum lung expansion and also to expand the diaphragm to go down. And also, we're going to have to check for the symmetry of their chest. That is all about assessment. And once there is no response at all, if you're checking the patient's O2 sat as well, you got to check that. Check oxygen saturation. Okay, how is the patient doing? Is the patient hypoxemic? Do they have a saturation of 80% or 89? Yeah, definitely you need to apply the oxygen once you know that the patient is hypoxemic, right? Another is that you probably would have to review the patient's other vital signs. Is the patient hypotensive? Is the patient in a lot of pain? Okay, because if it's related to some of the things, maybe they're in severe pain. We need to address that as well. We have to check the medical provider's order to see if there's any analgesic that may be able to help the patient. Okay. Now, let's take a look into letter B. So A is correct. What about letter B? Chest shape is equally wide from front to back. That simply means that the patient has barrel chest. Okay. So it's no longer 1:2. The anterior-posterior lateral ratio of the patient's rib cage is already 1:1, equally wide from front to back. So this is barrel chest that, again, will occur for quite some time. It's not going to happen overnight. So nothing really that you can do in the immediate phase about the barrel chest. But But you can do here is to investigate further if the patient may have some other manifestations, right? But nothing you can do about the chest shape at the moment. But what about letter C? Both lungs show reduced expansion. Will that concern you? Letter C. Well, the decreased lung expansion is actually expected in COPD. Nothing surprising about that. This is expected in COPD. Right? The reason for that, it's because the patient has already hyperinflated their alveoli, okay? So it has been going on for quite some time, and there is also that reduced lung elasticity, okay? Reduced elasticity of the alveoli. And also there is hyperinflation of the alveoli. So this is nothing shocking for this patient, all right? So this is what it's referring about. This is expected in COPD. Both lungs show reduced expansion. We're not talking about the size of the rib cage here, but it's actually the movement of the chest wall, okay? So it kind of looks kind of steady. Their rib cage is already large, anterior, posterior, but you're not going to see a whole lot of like inflation and deflation of the lungs. Now let's take a look in letter D. Percussion produces an unusually resonant sound. So this is going to be a common observation in COPD. Why? Hyperresonant. Why is it that the patient's lung sound will be hyperresonant when you are tapping the chest, when you are percussing the chest? The reason for that, it's because of the hyperinflation. There is trapping of the gas inside the alveoli. So it will sound like you are tapping into a drum set, okay? It has that kind of aerated sound, all right? So this is not something that you should be surprised about regarding a patient with COPD. Okay, so, all right. Answered, we got Roberta answering A, Tablea C, Kelly answered C as well. So our correct answer here is a respiratory rate of 38 breaths per minute. Even myself, if I have a patient that may have been a fresh post-op patient, let's say their respiratory rate probably would be around 24, 23, 22. And when you go back into their previous vital signs, take a look. What is their baseline? Are they on the same kind of range during the arrival or during the first day of the admission? So you really need to review the medical record, guys, okay? Aside from just looking into the current respiratory rate. Because, for example, if you started your shift, let's say, for example, the patient's respirations will be around 20, and then maybe an hour later on, it kind of went up to 24, 23, then something is not right there. Even though it's not that critical, you have to pay attention what's really causing that elevation of the respiratory rate. It could be pain, it could be a lack of oxygen. So don't ignore those, because the respiration really is one of the highly ignored vital signs. Trust me, it is one of the highly ignored vital signs. And I've seen nurses as well documenting the respiratory rate that's not really the right respirations. Remember, in the fundamentals of nursing, when you're supposed to count the respiratory rate, you have to do it in about 30 seconds, right? And multiply it by 2 if the respirations is regular, right? But if you'll notice, if the respiratory rate is irregular, you have to count the respirations for a full minute. The same thing with the heart rate. And so, like I've said, it is an easily neglected or falsely documented vital signs. I am 100% of that because people are not really religious in doing the respiration assessment. So we're going to go back to fundamentals. Make sure you do this and make sure you investigate further what was the patient's baseline is. Okay, so I hope that would be helping you with the assessment, especially with the respiration. Okay, so again, letter A, it definitely needs immediate action. It is a critical indicator that the patient has a compromise in their oxygenation. Okay, and it could be that the patient may have a DKA, right? We don't know. We don't have that information, but there are so many things that can be associated with a rapid respiration, and definitely we need to investigate that. All right. All right, and once you have generated your nursing diagnosis, and definitely act on it right away. Now let's move forward with the next question here. Question 17. It says, a nurse examines the chest of a patient diagnosed with a pneumococcal pneumonia. What finding would the nurse anticipate? Again, question 17. A nurse examines the chest of a patient diagnosed with a pneumococcal pneumonia. What finding would the nurse anticipate? Is it A, increased vibration when touching the chest? Or is it B, dry cough without phlegm? Or C, very resonant sound when tapping the chest? Or D, rubbing sound during auscultation? Again, a nurse examines the chest of a patient diagnosed with pneumococcal pneumonia. What finding would the nurse anticipate? Is it A, increased vibration when touching the chest or palpating the chest? B, dry cough without phlegm? C, very resonant sound when tapping the chest? And D, a rubbing sound during auscultation? Take your pick, guys. All right. While you're answering, I'm going to have to do the rationalization right now. So what is letter A about? So letter A, increased vibration when touching or palpating the chest. This is basically referring to the tactile fremitus. Okay. And when there is increasing tactile fremitus, as we have talked about yesterday, if there is increasing vibration, then what does it signify? What is the probable reason for that? As I have said yesterday, it could mean that there is now what? Consolidation of the lung tissue, right? So let me write that. Oh boy, why is this making it hard for me to write? Oh my gosh. Let me try one more time. Consolidation. And we are talking about consolidation of fluids in the alveoli. So when the patient says 99, and while you are palpating the chest wall of the patient, you will see the vibration that is going to be increased. All right. So you can do this in the anterior and also the posterior chest. Make sure that they're going to go through the 99 up until you're finished. Okay. So probably if your hands are kind of calloused, that would be quite difficult, but at least feel the increasing vibration. That's not a good sign, right? And so with this tactile fremitus being increased, this could suggest that the patient may have the pneumonia. Okay. Increasing vibration. Okay. Now, the vibration is also going to set in because of the solidification of the lung tissue, and this will also enhance the vibration through the chest wall when you're doing that. So, what about letter B? Dry cough without phlegm. Okay. So, with the pneumococcal pneumonia, okay, I really want you to pay attention here. We're talking about pneumococcal pneumonia. This is usually going to represent a productive cough. So your observation in letter B is quite the opposite. Not a dry cough, but it should be productive cough. And with the infection going on, it will lead to some more mucus secretions because of the inflammation. The exudates will be more in volume, all right? So we are eliminating letter B. What about letter C? Very resonant sound when tapping the chest. Hyperresonance or very resonant sound is associated with the emphysema. Okay, please don't forget that. If the sound is kind of air sounding, it's just like you're tapping in a percussion instrument. Boom, boom. You actually will feel that when you are tapping into the chest wall. So you really need to go through the tapping from the upper to the lower section of the chest, okay? And most often you will feel the consolidation to the bottom. So let's say, for example, okay, so we're talking about pneumonia. So what you're going to expect here is not hyperresonant, but there will be dullness, okay? Because of the consolidation. So resonance is out. This represents emphysema. So we are not going to choose that one. Okay. So again, in pneumonia, you will be expecting dullness. To else. Let me rewrite that. To else. Dullness. If there is fluid consolidation. Now let's take a look at letter D. A rubbing sound during auscultation. What does that represent? Well, this is the grating sound. And this is not really expected in a patient with a pneumonia. It indicates that there is already an inflammation of the pleural surfaces. Okay. So the visceral and the parietal pleura will be rubbing each other, and this is going to cause that grating sound. Okay. Pleural friction rub. Okay, I'm seeing a note here from Obey, dullness. Okay, let me clarify if you got confused. The dullness is the manifestation of pneumonia. And the reason for that, it's because of the consolidation. Okay, I am referring to this selection here, letter C, very resonant sound when tapping the chest. This is incorrect because this signifies that the patient has COPD, the emphysema type. Okay, so that makes it wrong. All right. What about Nigel? Nancy, what is your question? Okay, let me go back to the chat box once I'm done here and once I get clarification of your question. And so letter D is also incorrect because that doesn't really signify that the patient has a pneumococcal pneumonia. It will signify that the patient may have a different kind of lung disorder, such as in the pleuritis, okay? The pleural friction rub, all right? This is not typical of, does the question require a follow-up or a normal finding? This is actually asking us what assessment finding or what clinical feature you should expect in a person with pneumococcal pneumonia. So it's not asking us to make further assessments. It's not asking us for a normal finding. What this question is asking is to check you as the test taker if you're able to identify that abnormal finding in a patient with pneumococcal pneumonia. So what is that classic manifestation in a pneumococcal anemia that you should expect in this patient? Okay, so it's not asking about furthering or asking you to further assess. Okay, it's asking you to simply, okay, what is the manifestation of this patient? Okay, all right. So that leads to answering letter A, which is basically increased vibration when touching or palpating the chest. Okay, this is what we call as the increasing tactile fremitus. All right, so I hope that you were able to get what I am talking about. Yeah? All right, very good. Don't forget, tactile fremitus is one of those easily neglected assessment scale as well. All right, I've rarely seen people doing palpation on the chest wall. Rarely. And also with the auscultation, probably I've seen nurses auscultating the chest for like 1 or like 3 seconds in one segment and then shifting to the next. That's not the right way of doing the auscultation, guys. You really need to listen to the airflow with that one cycle. Make sure that you're able to hear any adventitious sounds, okay? Because what I'm seeing, like they're like shifting the stethoscope like within 3 seconds in so many spots. I mean, like, hey, what is that skill? It's like pretending that they're actually listening, and it's not the right way of doing that auscultation. So going back to the fundamentals of nursing, make sure that you do it correctly. All right. So with this, again, our answer here is letter A, increased vibration when touching or palpating the chest. Checking for tactile fremitus. That is our correct answer. That is associated with pneumococcal pneumonia. The rest are associated with other problems. Let's say emphysema for letter B. Letter C, emphysema, dry cough without phlegm. This is exact opposite. We're going to eliminate that. And D, it's not a typical manifestation of pneumococcal pneumonia as well. So your strategy here, guys, is to make sure you have to go back to the pathophysiology, the clinical findings. Make sure that you understand the signs and the symptoms of pneumococcal pneumonia. Okay, so let me enumerate those manifestations. So make sure that we are clear onto the signs and symptoms. So for the pneumococcal pneumonia, the manifestations that will be commonly seen are increasing tactile fremitus, another is when you are percussing the chest wall, there will be dullness because of the consolidation. Okay. And also there will be productive cough because of the increased mucus production in the airways and the alveoli. Increased productive cough. So you're going to expect here some more of the sputum, which could be purulent, or it could be tan in color and telling us that there is an active infection going on. Purulent or tan colored sputum. All right. So there are so many, but of course we're talking about like the most common and priority, or not really priority, but the most commonly seen manifestations in a patient with pneumococcal pneumonia. So please don't forget these, okay? Now, our goal here in answering this question really is to make sure that we are also eliminating those other choices that are not related about pneumonia, right? So like the pleural friction rub, the hyperresonance, or let's say the dry cough, those are not typical signs of the pneumococcal pneumonia. All right, I'm repeating myself all over again. All right, let's move on to the next question. Question number 18. A patient recently admitted with pulmonary edema is scheduled to receive the following medications. All right. A patient recently admitted with pulmonary edema is scheduled to receive the following medications. Which medication should the nurse question before administering? Is it A, carvedilol 3.125 milligrams tablet PO, or B, digoxin 0.125 tablet PO, C, furosemide 60 milligrams tablet PO, or D, captopril 25 milligrams tablet PO? Our situation here is about a patient admitted with pulmonary edema and is scheduled to receive the following medication. And it's asking, which medication should the nurse question? So it's basically wanting us to determine what medication should you question, or let's say kind of like doubt. Why is this medication given for this patient or ordered for this patient? So it's basically questioning the medication or the medical provider's order for this patient. Okay. Or let's put it this way. The medication that it's asking is something that would not be indicated for this patient with a pulmonary edema. Something that could harm the patient at this point. Okay? So I really want you to go back into the different drug actions on each medication. We got the carvedilol, digoxin, furosemide, captopril. Make sure that at least you know the drug classification so you will understand why is this medication indicated? Why is this going to benefit the patient? Or is this a medication that will harm the patient? Okay. Your answers, D, B, D, B, and B, and B. Okay. Pulmonary edema, guys. Remember about what could possibly cause the pulmonary edema. Okay, let's go back to the cardio because it's closely related to the respiratory concept, especially. So, the pulmonary edema basically is one of the complications that can occur in a patient with what? Wish me luck this time. Gonna try the pen. The left. Oh boy. I'm really trying hard with this pen. Why it doesn't work for me? Okay, let me try again. Ay. Okay, let me just use my mouse. I hate using my mouse, but I have no choice. Okay, the pulmonary edema. Let me just shorten that one. The pulmonary edema is basically that condition that is life-threatening, okay? And this can be a complication of the left-sided heart failure, okay? Pulmonary edema is a medical emergency that you need to deal with immediately, okay? You should address this immediately because this is a complication of your left-sided heart failure. Basically, what is going on here is that the patient, so let me just kind of like present this to you in a much more of understandable diagram. So let's take a look here. These are your air sacs, right? And we have the capillaries. Okay. So in the case of pulmonary edema, basically what's going on here is that the capillaries, the pulmonary capillaries are congested. They are engorged because of the backflow of the blood coming from the right side of the heart, okay? And so what's going to happen here is there will be some congestion. There will be increasing pressure. The hydrostatic pressure in the pulmonary capillary is very high. Remember about the hydrostatic pressure? This is the pressure that is exerted by the blood or the fluid against the blood vessel wall. And so when this happens, this will now become more permeable. And what happens is that the blood fluids will shift into the alveoli. There is that pulmonary edema. And so the patient will end up with fluid-filled alveoli. And what do you think can happen here? There will be low oxygenation. There will be poor oxygenation because of what? The presence of fluids that will not allow the exchange of the gases, right? So there will be hypoxemia. There will be respiratory distress, all right? So I hope that you understand here why the pulmonary edema is a medical emergency, all right? So what are we going to do here with this question? You're going to have to look for that medication that can cause more harm to the patient rather than helping the patient. Okay, so let's go through the options. Letter A. What is letter A? Letter A is known as a, let me write down here. It is known to be an alpha 1. It is also a beta 1. It's also known as the beta 2 adrenergic blocker, okay? So it's known to be an alpha 1 blocker, beta 1 blocker, beta 2 blocker. So basically it's used as an antihypertensive medication, okay? And in this scenario, our patient is admitted with pulmonary edema. It's not a chronic thing. It doesn't always happen. The pulmonary edema can occur when there is fluid overload. This is a rapid change in the patient's pulmonary circulation, okay? So the reason that they're admitted, it's because of the pulmonary edema. And so if we are talking about the carvedilol, what it can actually do is that it can actually worsen the heart failure. Okay? Why? Well, it's because that medication, let me erase this section right here. So the alpha 1 blocker or the beta 1 blocker, beta 2 blocker, it's actually a combination of, there's a whole lot of actions that a carvedilol can do. All right. So what can happen if we are going to administer the carvedilol? Well, it can decrease the heart rate. Another, it can also reduce the contraction of the heart muscle. So the strength of the ventricles, especially the muscles, the ventricles actually will be impaired. Yeah. And like I've said, pulmonary edema is already a complication to a pre-existing left-sided heart failure. And so if there is fluid overload, maybe the patient has been taking way too much fluid at home, not watching in their fluid intake, then they are overloaded, right? And if we're going to give them the carvedilol, it will worsen their pulmonary edema and also the congestive heart failure because it can decrease the force of the contraction of the ventricles, all right, or the atria. The muscle, the myocardium itself will be impaired at this point if we're going to give the carvedilol. So it's contraindicated in a case of a pulmonary edema. Or this is also contraindicated, guys, when there is what we call as acute decompensation of the heart failure. Acute decompensation. Okay. Basically, this is the worsening heart failure, decompensation, HF. Compensated heart failure, rather. Okay. So you might know this medication, that this can benefit the patient when they are not in an acute heart failure. Okay. Please take note of this, guys. I did not say that the medication will not help in a patient with heart failure. It can. However, it's not supposed to be given in this situation wherein the patient has worsening heart failure, because like I've said, it will further reduce the force of the contraction of the myocardium. Okay, the carvedilol will only be indicated when the patient's congestive heart failure is much more stabilized. Okay, again, that is the caveat here. Okay, we will only see the carvedilol as part of their treatment only when their heart failure is more stable. Okay, they're not having the pulmonary edema. All right, so I hope that you're able to understand really why we are not supposed to give the carvedilol in a case of pulmonary edema as a complication to left-sided heart failure. It's because of this reason. We don't want to decrease the contraction force further. That's a big no. All right, so let me get rid of this. Let me clear this so we can proceed with the next medication. Let's take a look onto the digoxin. What is the digoxin all about? Remember about this when I mentioned about the pulmonary hypertension? The digoxin is what we call as the cardiac, what's going on with my mouse? Cardiac glycoside. Ooh. Cardiac glycoside. Try again. Okay, I got lucky this time. So what is this medication? The cardiac glycoside, represented by the digoxin, it's basically gonna do so many things. One of those is a positive inotropic effect. What does that mean? A positive inotropic effect simply means that it will improve the myocardial contraction. Here we go again. It's very temperamental, so I'll just end up using the mouse. Myocardial contraction is going to be enhanced by the digoxin. So that is what we meant about positive inotropic effect. Okay, so the strength of the myocardium is going to be enhanced. It will promote that contractility, so it will end up with a good cardiac output. So this is going to be the total amount of blood that will be pumped by the heart every minute. As we know that the total cardiac output per minute is about 4 to 6 liters per minute. Okay. In a case of congestive heart failure, there is a decreased cardiac output. Why? It's because the ventricles are weak. It's not able to properly pump the blood out of the heart into the systemic circulation, and the person will end up with low blood supply to the organs, right? And we also have the next effect of the digoxin, really. And so what is that other effect? We call that as a negative chronotropic effect. I hope that you still remember this in pharmacology. What is negative chronotropic effect? It actually pertains to the lowering of the heart rate. Okay? Negative chronotropic effect. It will slow down the heart rate. Okay? What about the next effect here? We have the dromotropic effect. That's another therapeutic action of the digoxin. Negative dromotropic. D-R-O-M-O-T-R-O-P-I-C. So what does that mean? It will slow down the conduction of electrical impulses. So let me just put arrow down. Electrical impulses. So this simply means that the impulses that are supposed to be transmitted by the AV node into the bundle of His will be somewhat slowed down, and this is going to help out in managing any of those abnormal electrical activities. And that is why the digoxin is helpful in treating arrhythmias, okay? Because it has that negative dromotropic effect. And so just simplifying things here, digoxin can strengthen the contractility of the heart muscle. It can slow down the heart rate. And also it can slow down the transmission of the electrical impulses from the AV node to the next section of your electrical system. So that is why it is an effective antiarrhythmic agent. And we will talk more about the other properties here. And so what do you think about the digoxin? It is going to be a drug that you will expect to be administered in a case of a patient with a pulmonary edema and congestive heart failure. So we are not eliminating that, okay? What about letter C, furosemide? What is furosemide? Let me erase this. Furosemide is classified as a loop diuretic. It will get rid of the extra fluids inside the body. And it will also get rid of the excess fluids that are in the pulmonary circulations. Remember about those capillaries that are engorged? They are fluid. It's just the pressure inside the pulmonary circulation is just way too high because of the increasing blood or fluid that is building in the pulmonary circulation as a complication to the left side heart failure. And so we are going to have to give them the diuretic furosemide. This is a rapid acting medication. Why am I saying that this is a rapid acting diuretic? Well, because it will have an onset of about 5 minutes. When you are giving the medication IV, immediately within 5 minutes, your patient will be diuresing. You will see that they will be peeing a lot from having a urine color of, let's say, yellowish orange. Yeah, right away, within that time, when the medication starts working, they will be peeing colorless urine because it's actually going to pull all those extra fluids from the bloodstream and it will be excreted through the kidneys. All right. The onset is 5 minutes and it will last for a good 6 hours. Okay. About approximately around that. That's why it's called Lasix. Okay. 6 hours duration. So the patient around this time will be diuresing. And I hope that you have an experience with this patient that may have a pulmonary edema. And once the nurse gives it to them, they will feel some relief with the shortness of breathing from the fluid congestion in the lung fields because the onset of the medication is so fast. Okay. So by the time maybe 30 minutes later or 40 minutes, there might be some shortness of breath, but there will be a significant improvement as to the oxygen saturation. The respiratory rate will be much better this time. The respirations will probably be lowered from 30s down to maybe mid 20s, and eventually it will stabilize. Okay. So that's how this medication has helped a lot of patients, especially in a case of pulmonary edema. Think about Lasix. All right. This is a savior to our patient with a pulmonary edema. Okay. So we are not eliminating furosemide this time. What about letter D, captopril? What is captopril? Let me erase this. Captopril is an ACE inhibitor. It stands for angiotensin converting enzyme inhibitor. Angiotensin converting enzyme inhibitor. ACE-I. So what is this medication for? That medication actually will, let me go back into my past slide regarding the angiotensin system. So you will have a better understanding about what is the mechanism for the ACE inhibitor. Okay. Remember this slide that I used during our renal concepts? Okay. So this is basically the RAS mechanism, the renin-angiotensin system. Okay. And this is something that will be stimulated or will be activated if in case there is a drop in the blood pressure, right? And so this will lead into so many things. So when there is a blood pressure drop, or let's say a lack of a circulating fluid volume, this will allow the kidney to release the renin, right? And when that happens, it can also allow the release of the angiotensin 1 by the liver, okay? And once the blood goes through the pulmonary circulation in the lungs, it will be converted into angiotensin 2. Okay, from an angiotensin 1, the ACE will convert that into ACE, or it will convert that into angiotensin 2. Okay, so here's the thing. When the angiotensin 2 is made as a result to the conversion, it can do a lot of things. It can constrict the blood vessels, and eventually it will help stabilize the blood pressure. Okay. Another thing is that the angiotensin 2 can also stimulate the adrenal cortex to release the aldosterone. And when there is aldosterone release, it can lead to the reabsorption of sodium and also the chloride and also the water. So this will now cause the stabilization of the blood pressure because of that retention. So this is the normal mechanism, guys. However, in a case of the congestive heart failure, there is what we call as a derangement of the RAS mechanism. It's because of the low perfusion to the body organs. Remember about the low cardiac output? And so what's going to happen here, it will stimulate the RAS mechanism, and it will do a whole lot of issues. And so when we are talking about the ACE inhibitor medication, captopril, those pril drugs, lisinopril, captopril, what else? Enalapril. These medications will actually block the power of the angiotensin converting enzyme. It will render this enzyme powerless. Okay? So when this happens, there will be no conversion of angiotensin 1 into 2. So you will not expect retention of the aldosterone or no release of aldosterone. There will be no reabsorption of the sodium, chloride, and water. And there will be no vasoconstriction because the medication will block the function of the ACE, which is the enzyme that's supposed to convert the angiotensin 1 into 2. Okay? Are you getting what I am saying here, guys? So that is the reason why ACE inhibitors are also going to be beneficial in the treatment of congestive heart failure. All right? So let's go back to that slide. All righty, where are we? I think over here. Just wait. Oh, here we go. ACE inhibitor. So again, the mechanism of action for this medication, captopril, it will block the action of the ACE. There will be no conversion of angiotensin 1 into angiotensin 2. And so again, our results here will be no hypertension. There will be no reabsorption of sodium and chloride. So let me just write here, water, chloride, and sodium. None of those will occur because of the captopril. All right. So do you think this is going to be contraindicated in the treatment for this patient with pulmonary edema and congestive heart failure? Of course not. It's going to benefit the patient. So we are left with the letter A. So do you remember about the effects of the carvedilol? It can decrease the cardiac output. So this will harm the patient around this time. So this is our answer, because we are looking for that medication that you should question. Okay, so the correct answer here is the carvedilol, not digoxin. Okay, I'm puzzled. Mary Akugri, you said no. What does that mean? Okay. So again, we are looking for that medication that you should question in the list. Okay. Carvedilol is a drug that should not be given to this patient. Okay. So our strategy here, guys, is for you to make sure you understand the drug mechanisms, the classification where they belong. Because if you don't know the classification, you will not be able to eliminate this, especially if you're going to be asked, is this medication going to harm the patient, or is this medication going to help the patient? So again, our drugs here that will benefit the patient will be the following: digoxin, furosemide, and captopril. All right. All right. The furosemide will decrease the fluid overload or treat the overload, while captopril will also decrease the reabsorption of the water, salt, chloride in the kidney tubules, because we want to get rid of the excess fluids. We don't want to cause reabsorption. That's why the captopril will be effective as well. You were asking if ACE is contraindicated in pulmonary. Okay, I gotcha. Thank you. So ACE is, if you're ACE, okay, I want you to be specific here with the ACE. If we are talking about the ACE inhibitor, not just ACE, because ACE is the enzyme. So if we are talking about the ACE inhibitor, it is going to be part of the treatment for the pulmonary edema, okay? Not contraindicated. All right, just to be clear, ACE inhibitor will help in the treatment of this patient. It's not really the primary medication that we will be giving, but it will also help out in the treatment, okay? In the case of pulmonary edema, this will be our mainstay, furosemide. It has that rapid action to decrease the fluid overload. It will cause excretion of way too much fluid in the lungs, in the circulation, okay? So furosemide is the top most needed medication here, and then followed by the digoxin and the captopril, okay? All right. Now, the digoxin is actually intended for the congestive heart failure. Like I've said, it can cause increased contractility, increasing cardiac output. It will decrease the rapid heart rate. It will also decrease the, it will slow down the impulses coming from the AV node. So it has that antiarrhythmic effect. Now let's move forward with the next question here. A patient diagnosed with a pulmonary embolism is receiving a treatment with continuous heparin infusion. What diagnostic finding indicates to the nurse that the treatment is effective? Again, the question states, a patient diagnosed with pulmonary embolism is receiving treatment with continuous heparin infusion. What diagnostic finding indicates to the nurse that the treatment is effective? So what you're seeing here, guys, are lab values. So pretty much just asking you what lab value is gonna signify or will let you know that the heparin infusion for this patient with a pulmonary embolism is effective, okay? So basically, it's asking you what lab study will be a good indicator, parameter that will help you determined that the medication is actually working for this patient with pulmonary embolism. John Pearl Fernandez, hello. Cephas answered D. We got Bethany D. We got Mary answering D. Charmaine McGill Franklin answered D. All right, this is a very common question, especially when you are being asked in a case of, let's say, a person that may be having pulmonary embolism, or it could be a anticoagulation in treating a patient with deep vein thrombosis. Guys, yes, this is a very common question that may come out as well. We are talking about the anticoagulation, how effective the anticoagulation is. All right. Heparin. Let's talk about this one before we move forward with the options. Let's talk about what a heparin is. So what is this medication? Basically, heparin is one of those medications that will cause the anticoagulation. Basically, a heparin will prevent formation of more clots. Prevents more clots, or it will prevent the growth of clots. So in a patient with a pulmonary embolism, when the clot is lodging in the arteries or arterioles or capillary, it will prevent the growth of the clot. So basically, the size of the clot will remain the same if we had started the anticoagulation right away. So it will not grow, okay? But the clot is still lodged into the pulmonary artery or the arteriole or the capillary. Now, the heparin, which is going to be administered IV, okay? So this is going to be an IV infusion, not subcutaneous. If we are talking about the subcutaneous, that is not going to be an appropriate form of therapy, because it's not going to really, well, you don't want to inject, or you're not going to administer so many of the subcutaneous injections throughout the day. We don't want to do that. So it has to be given as an IV infusion. And with the IV infusion, it will be regulated, it will be titrated according to the lab value known as the APTT, which is the activated partial thromboplastin time. And with that, this will be our reference to see if our medication heparin is already therapeutic. It simply means that the heparin probably is in that safe range, the expected level where it can prevent the formation of more blood clots. Okay, so that is why we are going to answer letter D, activated partial thromboplastin time, which is going to be at least 1.5 to 2.5 times the control value. Okay, so here, when we are talking about the APTT, normally, guys, when we are referring to an APTT, so we'll talk about a person that does not have heparin yet, okay? So let me put here non-heparinized, or no heparin treatment, no heparin, non-heparinized blood, okay? So the normal value of the APTT, it is going to range from 25 to 35 seconds. That is the normal value in a normal person with no heparin in their bloodstream. That is normal, okay? So when we are talking about APTT, therapeutic level in a person taking the heparin infusion, it will be about 1.5 to, let me put the digit right there, or the decimal, 1.5 to 2.5 times the control value. So for example, if we have, let's say, an upper limit of 35, okay? So we're going to find that upper limit. So 35, which is basically the upper limit, let's say we're going to multiply it by the 2.5. So around 87.5, the upper limit right here. So when we are seeing the lab value as 87.5 second, this is going to be the upper normal limit wherein the person is in a safe range that the medication is going to anticoagulate. It will thin the blood to prevent the formation of more blood clots. Now let's take a look into the lower limit right here. So let's take a look into the 25 lower limit. We'll multiply it by 1.5. So the 37.5 will be considered as the lower therapeutic level, okay? And we are talking about the APTT in seconds. So when the patient will be within this range, and it might vary, guys, in some hospitals, they might have a different reference range, but at least we know where that anticoagulation can occur, all right? And so there are so many protocols. I've seen so many protocols when I am giving anticoagulation to my patients with DVT and the PE. And so it can vary slightly from one hospital to the next, but in general, there will be that allowed range of anticoagulation when we are talking about the heparin, okay? So this is just like a general anticoagulation range. So basically, when we are referring to this, this is going to prevent the formation of more blood clots. It will prevent the growth of the blood clot. Okay, so that is about the APTT. So let's talk about the letter A. What is this letter A? Prothrombin time, PT, is within normal limits. Do you think this is a good answer or is this a wrong answer? Well, prothrombin time, or PT, it's going to be a lab testing that will be done when the patient takes warfarin, okay? The warfarin is another anticoagulant that will be taken by the patient once they establish that safe therapeutic range when they have taken the heparin. So for example, guys, let's say the patient was admitted with a PE, right? So for example, day 1, when the patient is admitted, in day 1, we'll start the heparin, IV infusion, okay? And the reason for that is to allow a much faster anticoagulation, okay? Because the medication will thin the blood really fast. And so we want to make sure that we are going to achieve that stable anticoagulation, like I have said, in the APTT range. So maybe about day 2, maybe day 3. So the patient's APTT level around this time will be more stable, okay? So you will expect that the patient will still be getting the heparin infusion with that kind of duration. But take note here that in order for the anticoagulation to be shifted from an IV form into the warfarin, the medical provider will also start ordering the warfarin, which is an oral anticoagulant, okay, which is a PO. This will also thin the blood. And you will notice this, guys, that maybe the medical provider will kind of hold off of not giving it during the first day. In some other cases, they might start giving or ordering the warfarin during the second day. And guys, the warfarin will take about 2 to 3 days to take effect, okay? It doesn't cause instantaneous anticoagulation. It will take good 2 to 3 days before it will actually start working. And that is why it can be given maybe during the first day or the second day, until when the doctors will see a much more stable APTT, they're going to decide that they're going to discontinue the heparin, okay? When the therapeutic level has been reached, let's say during the 3rd day or 4th day, they probably will discontinue the heparin infusion and will start, or they will continue ordering the warfarin let's say from day one, and the warfarin will be left as the anticoagulation, okay, or anticoagulant for this patient. Again, the warfarin will take good 2 to 3 days to take effect, and that is why it has to be given during the initial days when we are giving the heparin infusion. I hope that you're understanding the mechanisms here. This is what we call as bridging, okay? Because we don't want to administer the heparin infusion all throughout, because the heparin is also a rapid acting. However, the half-life it has is about 8 hours. So once the medication is discontinued, it will start diminishing its effect, and then there's no more anticoagulation if we're just gonna discontinue the heparin without the warfarin. So make sure that in order for us to continue the anticoagulation, the warfarin should be started in order to maintain that blood thinning, okay? So I want you to write down your comments in the section if you did not understand what I'm talking about. But again, the anticoagulation will be like that, especially with the use of the heparin and the warfarin. There will be that bridging in order to continue the anticoagulation, in order to prevent more complications. Now, going back to letter A, prothrombin time is within the normal limits. Again, this is not going to be a good measurement or a determinant that the patient is getting that safe anticoagulation range, because this is only intended to check the level of the warfarin, okay? And guys, when we are talking about the warfarin, the allowed or the normal PT and the INR, which is the international normalized ratio, and so when we are talking about the INR, I should say, no warfarin yet. So let me erase this because this is getting confusing here. Let me just erase that and the rest. So we are talking right now about warfarin. Okay. So in the normal situation here, without warfarin, normally the INR level is about 0.8 to 1.2. And the prothrombin time, which is going to be 11 to 13, eraser, 11 to 13.5. So that is the normal range for the PT and the INR when they are not getting the warfarin yet, okay? And so if we are giving the warfarin around this time, okay, usually the INR should be greater than 1.2, okay? Or around 1.3 to at least 3. That is our therapeutic range for the warfarin. Okay, so this is going to be our indicator that the warfarin is working properly. It is thinning the blood. It is going to work wonders in the bloodstream. It will prevent the blood clots. But again, we are talking about the heparin infusion. So this is not going to be a lab value that will be useful in this scenario. Okay, so we are removing that. For letter B, ABG showing presence of factor 8. Does it show? No, of course not. Eliminate that. The arterial blood gases will be helpful in giving us the idea of how well the patient probably is with their oxygen level, the carbon dioxide, the partial pressure of the oxygen, the bicarbonate level. And this is going to be so erroneous. It doesn't show the factor 8. All right. Now let's take a look on letter C. Platelet count is below 100,000 per cubic millimeter. So what is that? The platelet count is below 100%. This is actually thrombocytopenia, a drop in the platelet count. Remember, guys, that when you are reviewing the platelet count, normally it should be around 150K to about 450K. I'm talking about thousands here. 150,000 to 450,000. That is the normal range of your platelet count. However, with a drop, let's say 100,000, that is already considered thrombocytopenia. And so we are not going to use the platelet drop as an indicator that the heparin is working in the bloodstream. No. Actually, guys, let me just insert this. There is such thing as the heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia. So this is an adverse effect that can occur potentially, right? It's not on everybody, okay? But you got to be careful when you are administering the heparin infusion. You have to monitor the platelet count of your patient daily, okay? To capture if there is a significant drop, because when the patient has the thrombocytopenia, they can bleed out, and we don't want that, okay? And so we are left with the letter D, which is basically activated partial thromboplastin time. Okay, patient said that it's not clear with D. So somebody is not getting the explanation for letter D. Again, one last time here. The activated partial thromboplastin time is the only laboratory test that will determine the effectiveness of the heparin infusion. Okay, APTT, activated partial thromboplastin time. You should not be using prothrombin time or INR. You should not be using ABG or not use the platelet count as the basis to determine that the medication is therapeutic in the bloodstream. Okay, so again, the activated partial thromboplastin time in a person that does not have heparin, okay, again, the value is 25 to 35 seconds. So in this value, there is no anticoagulation, no heparin, okay? If we are giving them the heparin infusion, our goal for the APTT should be that 1.5 to 2.5 times the control value, okay? So if we are going to have to calculate that in order for us to determine that this medication is already thinning the blood, it's preventing, or it will prevent the formation of more clots, preventing the growth of the clots, you're going to have to find that therapeutic range. And as I have said earlier, what I did was actually calculating the 35, which is the upper limit, 35 seconds. And I am multiplying it with the 2.5, which is basically the determinant that, hey, your patient should be in this range. So again, what is that? 35 times 2.5. So that is about 87.5. 87.5 second. So this is the upper limit, okay? If your patient's APTT will be greater than that, then we don't want that too, because that simply can cause bleeding in our patient. Our patient probably will end up with epistaxis, bleeding in the GI tract. It could probably cause some epidural bleeding, okay? We don't want to go beyond that value, okay? Now, if we're gonna look for the lower limit of anticoagulation, what I basically did earlier was to multiply the 1.5 by the lower limit. Yeah, Munther Ali, yeah. 1.5, you're going to multiply it by the lower cutoff, which is 25. So that would be like around 37.5, as I have shown you earlier. So this is just like a simple calculation. Like I have said earlier, the therapeutic range from one hospital to the next could slightly vary, okay? And we are talking about the number of seconds. Again, if the patient's APTT will exceed 87.5, that would be unsafe. That would be too much. So we are going to adjust the IV infusion. We're going to have to reduce the flow rate of the heparin because we don't want to exceed the acceptable range. Now, if the value is going to be lower than 37.5, that simply means that the medication is not enough in the bloodstream. It's not thinning the blood. It will not do any therapeutic effect. So it will render ineffective. So what we're going to do, we're also going to have to increase the dose of the heparin if the value is lower. Whereas if the value is way too much, we're going to have to decrease the infusion. Okay? And I'm not going to go through the different increase and the decrease because it's a whole lot different gamut right there. You have to use the tables. Yeah, I have done so many of these infusions way back. You really need to keep an eye, guys. Make sure that the blood draws will be done in a timely manner. So for example, if the APTT will come back 101 seconds, that is a critical value. You don't want your patient with that high value. And most often what we're going to do immediately, if the critical value comes back very high, then we're going to have to stop the infusion, disconnect the tubing, and let the patient be off the heparin for quite some time. And it will vary from one hospital to the next. Maybe they want to keep the patient off the heparin for, let's say, good 1 hour. And then after an hour, there's going to be another APTT to be drawn to check if it has kind of like go back to the normal range, or maybe it's decreasing up until it goes back to that safe range, which is this. Okay. And once the patient goes back to that safe range, we're going to have to titrate that medication or have to allow that flow rate in that safe range. Okay, so it's very complicated, guys, but that is not our focus. I'm just showing you here the importance of monitoring the activated partial thromboplastin time. Okay, so like I've said, if it's greater than the allowed value, you're going to have to decrease the rate or maybe discontinue. Or if it's lower than the lower limit, then we're going to need to probably increase the infusion in order to allow anticoagulation. All right, so that is about the heparin, okay? Now, when we are talking about the heparin infusion here, as I've mentioned earlier, you got to keep an eye on the bleeding tendencies. This is a biggie. So one of those nursing actions that you will be doing is to check for signs and symptoms of bleeding. It could be bleeding from the nose, or it could be bleeding from the IV site, or it could be bleeding in the rectum. If the patient is constipated and if they're going to be bearing down so much, it will cause some bleeding into the rectum. Yeah, that's going to be an issue, guys, because the patient will probably not stop bleeding there. So what you're going to need to do is to watch for the urine color. That's another one. Watch urine color. Watch for the stools. Watch for epistaxis, gum bleeding, and bleeding from the IV site. So these are just a few of the interventions that you should be applying to this patient. Again, watch the patient for any bleeding manifestations. Again, look for a discoloration in the urine. Maybe they're going to end up with hematuria. Or look into the stools. If there is now black discoloration of the stools, and it could be probably a significant change from being brown to black within 24 hours, that's not a good thing. Maybe the patient now has rectal bleed or upper GI bleed. So we want to make sure that we are letting the medical provider know so they can order stool exams, guaiac stool, so we can determine if there is some bleeding going on the GI tract. All right. And aside from that, we're going to have to do a whole lot with preventing trauma to the patient. Make sure that they are not using the straight razor, right? No straight razor for this patient during the anticoagulation. No straight razor. We're gonna have to let them use the electric shaver instead. We're not gonna allow them to do dental flossing because it can cause bleeding as well. None of that. And as far as brushing their teeth, make sure that they're gonna be given the soft bristled brush. And of course, if the person is elderly, they might be unsteady, a fall risk. You got to be mindful of that as well. Make sure that you are not letting them get out of the bed by themselves. If they are fall risk, not a good idea. If they are on anticoagulation, they can eventually fall and cause injury to themselves. Might end up with, bleeding in their internal organs. We don't want that. Okay, let's proceed with the next question right here. Way too much about the anticoagulation. It's a huge monster, guys. All right, talking about question number 20. A patient who was in a car accident now has a tracheostomy for ongoing mechanical ventilation. How should the nurse interpret these arterial blood gas results? So our pH here is 7.48. Partial pressure of the oxygen is 85 mmHg, and the partial pressure of the carbon dioxide is 32, and bicarbonate of 25 milliequivalents per liter. So this is your chance, guys, to review your ABGs. I know that probably you are a master of this, but for those who are not, take your time in understanding the ABG analysis. Okay, again, the question states, a patient who was in a car accident now has a tracheostomy for ongoing mechanical ventilation. How should the nurse interpret these arterial blood gas results? pH is 7.48. Partial pressure of the carbon dioxide, partial pressure of the oxygen is 85. Partial pressure of the carbon dioxide is 32. And partial pressure of, or not partial pressure, but the bicarbonate level is 35. Did I say? 25 rather. 25 MAQ. All right, I'm seeing your answers. D, Buzz Babe, D, Rodeline, D, Franklin, D, John Pearl, D, Mary, D, Sifa, D, Joyce, Bethany, Pauline, Obey. Okay. All right, so let's go through the different values here. Okay, wish me luck with the spin because this has been just trouble today. I tried to do a lot of this yesterday on my own and it worked well, but now it's not. Oh, bummer. Let's do this pen. Okay, let's take a look into the values here. Where is my pen? Oh, come on. Come on, come on. All right, so let's take a look into the pH. The pH is 7.48. So what does that mean? You're going to have to recall the room, right? 7.48. It is actually, I'm just going to stop using this pen. This is just not helpful. So bear with me with my handwriting using the mouse. So 7.48 is way beyond the value of 7.35 to 7.45. Okay, so this is going to be alkalotic, way high than the normal range. Okay, now let's take a look into the PaO2. PaO2 is 85. And remember that the safe range here is about 80 to 100, right? Okay, 85 is within the normal range. And we have the PaCO2, the partial pressure of the carbon dioxide, which is 32. And remember, guys, our normal value here is about 35 to 45, and we are talking about the pressure. So How is that 32? And remember that PaCO2 is basically acidic in nature, right? So when the value drops less than the 35 value, then this is going to be alkalotic, okay? Guys, to simplify things, if you are looking into the carbon dioxide, that is acidic usually, okay? Acidic. So if it goes below the normal range, then it becomes alkalotic. If it goes higher than 45, it is very acidic. So that's how I do this interpretation. Very easy. Now let's take a look into the bicarbonate, HCO3. And the bicarbonate is actually produced by the kidneys. It's basic in nature. It is alkaline. So our value here is 25. Is it in the safe range, or is it low, or is it high? Well, 25 is normal, right? Because the value is 22 to 26. So the bicarbonate is steady. It's like, I don't care. I'm actually normal right now. I'm not going to do anything. I'm already normal. That's what the bicarbonate is saying to the other blood gases. So our problems here are the pH, which is actually alkalotic, because it's greater than 7.45, right? It is 7.48. And the other one, the other problem here is the PaCO2, which is actually 32. PaCO2. And here, the value is 32. And like I've said, the PaCO2 is acidic in nature. If it goes below the lower limit, such as 32, then it is alkalotic. So, what do you see here in your observations here? What are you observing? Are they of the same direction, both alkalotic? Are they alkalotic? Are those two alkalotic? Yes. Both the pH and the carbon dioxide are alkalotic. However, our bicarbonate is not doing anything. It's normal, okay? So what are you seeing here? Well, when you are gonna look into the PaCO2, this is respiratory, okay? Respiratory, because it's talking about the partial pressure of the carbon dioxide. It's respiratory. Whereas the pH is basically telling us the acidity of the blood. So these two are kind of like, hey, we're best friends. We are the same. We are both alkalotic. So let's enjoy this. So this is really signifying here that the patient has respiratory alkalosis, because looking into the two issues, they're both alkalotic. And looking into the, what do you call this? The bicarbonate, it's not really doing anything. And so this is possibly going to be what we call as an uncompensated respiratory alkalosis, because the other one remains normal, okay? So that is the deal. We're going to do a lot more later on, which kind of I reserved a little bit. But this is just like a sneak peek for today. All right. All right. So I hope that you are getting a little bit more of understanding the basics of the ABG. I usually don't go by the room. I mean, yeah, that is, yeah, that's a lot of steps for me already. I just look by the numbers and I can immediately tell. So yeah. Yeah, the kidneys are fine. Yeah, it's not compensate. I mean, yeah, it's not responding to the problem. It's basically, hey, I'm okay. My bicarbonate level is normal. So deal with yourselves right there. It's actually uncompensated respiratory alkalosis. So moving into the next question here. A patient who was in a car accident now has a tracheostomy. Oh, okay. It looks like it's the same question. Let's move on to the next. A patient is set to undergo a chest CT scan with contrast. Which assessment findings should the nurse notify the healthcare provider about prior to the scan? Select all that apply. Let me reread the question because I got confused just real quick. So it said a patient is set to undergo a chest CT scan with contrast. Which assessment findings should the nurse notify the healthcare provider about prior to the scan? Select all that apply. Is it A, allergy to seafood? B, fear of confined spaces? C, high creatinine levels in the blood? And D, recent use of inhaled bronchodilator? And E, unable to take off a wedding ring. So what we are looking for here are assessment findings that are abnormal, that should be notified to the medical provider before the patient will be sent to the CAT scan with IV contrast. All right? Alrighty. I'm seeing some answers here. ABC, ABCE, AC, AC, ABC, 1, 2, 3. Okay. Alrighty. Now, we're going to go through the selections here. Remember about a CAT scan or CT scan involving contrast. Okay. Do you still remember about that preparation? What your role is when you are actually screening your patient before they go to a CAT scan procedure with that IV contrast. Yeah, we'll talk about that in a minute. Letter A, allergy to seafood. Okay. Well, this is going to be one of the correct answers. It's because the IV contrast that will be given in the CT scan, it will be given as an IV. It will actually contain iodine. And also, when the patient has a seafood allergy, they may indicate as sensitivity to the iodine, and this should be reported. Okay. So we are going to select this as one of the answers. Allergy to seafoods, because the contrast media is containing iodine. All right. Now, let's talk about letter B, fear of confined spaces. Well, when the patient reports that they are claustrophobic, this is also concerning, right? But will it contraindicate the CAT scan? No, it doesn't contraindicate. There are so many things that we can do to allay the anxiety of our patient. Okay, they might need some form of sedative or maybe a benzodiazepine before the procedure. When the patient agrees to take that medication, when the doctor talks to them about, hey, we note that you have claustrophobia, would you be able to get or to take this medication before you go for this procedure? Would you be able to take this medication? Would you agree to proceed with a procedure while we're going to give you a benzodiazepine in order for you to help relax? Okay, so this is not really going to contraindicate the use of the contrast media for that reason. All right. Yeah, I've had so many patients that have claustrophobia, but we are actually intervening the claustrophobia. Now, letter C, high creatinine levels in the blood. Yeah. The contrast media is going to be excreted by the kidneys. Okay. The exit exits in the kidney. So if your patient has a problem in their kidney function, that will be a cause of concern. All right. And so if there is going to be high creatinine levels in the blood, usually this is going to be a contraindication for a contrast media. Okay. Because if we are going to push through with the injection of the contrast media, it can now result to kidney impairment. It can potentially cause renal failure, right? So that's why we're going to select letter C, high creatinine levels in the blood. And again, what is the normal creatinine level, if I may ask you? Well, as far as I could remember, it ranges from about 0.7 to 1.1, in some books 1.2. It varies. in different literatures. It depends on what laboratory is being used, but this is our safe range for the creatinine. And of course, there is a variation between a male patient and a female patient. Most of the females that are not muscular, not bodybuilders, they tend to have a lower creatinine levels, okay, compared to the males who will be falling into this range, 0.7 to 1.1. So again, high creatinine levels will be contraindicated for, or the contrast media rather is going to be contraindicated for this patient with a high creatinine level, okay? So anything above this one, so it simply means that there is now impairment of kidney function. Or maybe in some scenario, you might be presented with an EGFR, which is the glomerular filtration rate, but rarely it will be. But just in case, just throwing it out there for you. Now, letter D, recent use of inhaler bronchodilator. Will that contraindicate the use of the contrast media? The inhaled bronchodilator really does not impact the safety and also the efficacy of the contrast media. So we're going to get this. We're going to eliminate letter D. What about letter E? Unable to take off a wedding ring. Yeah, kind of subtle, right? It simply means that the patient's digits are actually swollen, right? There is edema, okay? And so the patient here already has a significant edema with the digits. That is already a problem, right? So if there is presence of edema, it could signify that there is already a kidney function disorder, maybe because the kidneys is not able to get rid of the excess fluids, excess electrolytes, excess creatinine, BUN, and so this will be a source of concern. So this is going to be one of the answers, okay? So we are going to select the following. Let me highlight this. Allergy to the seafoods, high creatinine levels, and unable to take off a wedding ring, okay? So these two signals that there is renal impairment, okay? Whereas the other one is actually allergy to seafood. We don't want to cause anaphylaxis in the patient in the procedure room. So guys, your role here as an RN, you have to screen your patient. Make sure screen patient for iodine allergy. Make sure you ask this. If the patient is unsure if they have any iodine allergy, then your role here is to investigate further. You might ask the family member that could be familiar with the care or their history, or maybe ask their past medical provider, or maybe the pharmacist may have that information about their database, medication allergy. And so you really need to investigate if you are unsure if the patient knows or not know their allergy to the iodine content, okay? That is your responsibility, guys. And in my practice, the hospital that I worked with before, they're very good in screening. We have a form to fill out, making sure that we have done our diligent nursing screening. We have to fill out a form, which is basically going to be part of the medical record, that we have done our task in making sure that a patient is not allergic, or to notify or to document that the patient is allergic to the contrast media before we send them to the procedure room or the imaging department, okay? So that is our responsibility. Obey. Allergy to seafood. Okay, why? Okay, let me go back to the question. Which assessment findings should the nurse notify the healthcare provider about prior to the scan? So let go of 5. Okay, so this is one of the answers aside from C and D. So this is going to be important, guys, because if there is allergy to seafood, remember that the contrast media has iodine content, okay? And most of the seafoods also has iodine content. So this is a pertinent information. This is a critical information that needs to be relayed, that we should notify to the medical provider. Hey, doctor, my patient is allergic to shellfish. I don't think he's going to be able to go for the contrast media with the CT scan with the contrast. Hey, the patient has creatinine level that is 2.5. I don't think the patient should be getting this contrast media. Or hey, my patient right now, doctor, has some edema in their digits. Their rings is kind of stuck. They're edematous. That's a sign that there is renal impairment. So these are the things that you should report to the doctor. These are significant, okay? So again, the allergy to the seafood is a critical finding that you should tell the doctor about, because they should not be getting the contrast media. All right, so I hope that clears the confusion. Now, again, our role here, guys, is to screen our patient properly. That is our role before we send them to the diagnostic room, okay? We don't want them to develop anaphylaxis. They probably would end up with the anaphylactic shock if we are not screening them properly, or maybe falsely putting in their record that they are not allergic to the iodine or shellfish or seafoods. So make sure that you do your diligent assessment. Make sure that you ask thoroughly, okay? If you are not sure about the data that you are charting, then don't do it, okay? I'm serious here, because you don't want to cause any allergic reaction to the patient. Now let's move forward to the next question here. Question number 23. After listening to a patient with a tracheostomy tube, the nurse hears coarse crackles on both sides. If the patient cannot effectively, why not D? Like I have said, guys, our answers for this item is letters A, B, A, letter C, and E. I already explained this, okay? So for this item regarding the CT scan with contrast, our answers here are letter A, letter C, and letter E. The rest are not correct. All right, moving forward. Question number 23. After listening to a patient with a tracheostomy tube, auscultating, yeah, so it's basically referring to auscultating a patient with a tracheostomy tube, the nurse hears coarse crackles on both sides. If the patient cannot effectively cough up the mucus, what should the nurse do next? Okay, so the question states, after listening to a patient with a tracheostomy tube, the nurse hears coarse crackles on both sides. If the patient cannot effectively cough up the mucus, what should the nurse do next? All right, let's have the options. Letter A, advise a more frequent use of the incentive spirometer. Or B, suggest the patient drink more fluids. Letter C, don sterile gloves and suction using a sterile catheter. Now, what about letter D? Pre-oxygenate the patient for 3 minutes before suctioning. Okay, so this is a patient with a tracheostomy tube. Okay, so there is that surgical hole in order to allow the breathing, okay, the entry of the air, okay? But the scenario states that the patient now has coarse crackles. Crackles is my enemy. I don't like my patient to have crackles. It just stirs my soul. When I hear my patient having that adventitious lung sounds, I'm like, hey, are you going to pass out during my shift, or are you going to code during my shift? Yeah, I always think about the complications, guys. And so I'm on my toes. Every time I step on my nursing unit, I just expect something will happen. Something bad will happen. I just do that. So in order that I'm prepared to what to do. Okay, so coarse crackles is never good. And it said here, if the patient cannot effectively cough up the mucus, what you should do. So looking into your answers right now, you're answering letter D, some C. Okay, so let's take a look here about letter. Okay, so let's reveal the answer right away. So no further ado, the correct answer here is going to be, drum roll. Okay, let's take a look. The correct answer is letter C. Why? Well, the coarse crackles in both sides is already a sign that they're filled in their alveoli, right? They need to be suctioned right now. And why letter D is wrong? Pre-oxygenate the patient for 3 minutes. That's way too much. You are overkilling the intervention here, guys. You should only pre-oxygenate the patient for about 30 seconds, not 3 minutes. All right? Only 30 seconds. 3 minutes is way too much. You probably got fooled by the pre-oxygenate word, but this makes the statement wrong. 3 minutes before suctioning, pre-oxygenation, again, that's an overkill, okay? So what you're gonna do here is to basically make sure you're gonna don the sterile gloves and suction the patient using that sterile catheter, okay? All right? This is an issue about airway. Again, another critical assessment, all right? Crackles, coarse crackles in both sides. Are you not worried about the airway? Yes, we are. But like I said, this makes this wrong. The 3 minutes is an overkill. So we don't have any other option. The most correct answer here is letter C. Do the wearing of the sterile gloves and suction the patient using that sterile catheter. Okay, so that is a correct answer. Why not letter A? Advise more frequent use of the incentive spirometer. Yeah, we know that the incentive spirometer can facilitate the deep breathing, right? It can also open up the airways, and it can promote coughing. But with a patient that has a tracheostomy, no. How they can do the deep breathing when they have a hole here? It will not work, right? So we are eliminating incentive spirometry on this patient. What about letter B? Suggest the patient drink more fluids. Yeah, increasing the fluids can also thin the secretions, right? But it will not address the immediate need to clear the airway. Here is our immediate need: airway clearance, airway patency. We need to get rid of the mucus secretions, all right? Now, I already explained about letter D that makes it wrong because of the duration of hyperoxygenation. 3 minutes, really? No. We're only going to hyperoxygenate them for at least 30 seconds and do your suctioning. We want to get rid of the mucus secretions. All right. So there was only a few who got the letter C correct, and congratulations. And for those who tried answering letter D, also a good job, but try harder next time. Okay. All right. Let's move forward with the next question. After listening to a patient with a tracheostomy tube, the nurse hears coarse crackles on both sides. If the patient cannot effectively cough up the mucus, what should the nurse do next? Question 23. After listening to a patient with a tracheostomy tube, the nurse hears coarse crackles on both sides. Oh, is it identical? Sorry. Let's move on with the next question. Question number 24. Oh boy, I get so distracted looking into my iPad. I think I should stop looking into the iPad this time. So, you don't see 3 minutes? Okay, let's go back to that question. Yeah, we have the 3 minutes here. Pre-oxygenate the patient for 3 minutes, right there. Yeah. Virtuous lady, can you see it now? Yeah, there's that 3 minutes before suctioning. So again, we're only supposed to hyperoxygenate them for 30 seconds. Okay? All right. Let's move forward with the next question. I feel goofy right now. Let me just have a drink of water. The nurse is caring for an elderly patient in the hospital who has a nasal packing due to a nosebleed. Which observation requires the nurse's immediate attention? Okay. We did not include this in our discussion really, but yeah, this could possibly come out in your exam regarding the epistaxis, right? All right, the situation here said, the nurse is caring for an elderly patient in the hospital who has a nasal packing due to a nosebleed. Which observation requires the nurse's immediate attention? Okay. Letter A, is it oxygen saturation is at 88% in room air? Is it B, the nose is red and swollen? Is it C, the patient describes pain as 8 out of 10? Yeah, that's severe, right? Yeah, but don't get so distracted. Letter D, the patient's temperature is a 100.2 degrees Fahrenheit. There's fever. Yeah, good for you guys. You're answering letter A. I'm seeing letter A. I don't see anything weird right now. Good job. That is the correct answer. The oxygen saturation that is 88% in room air is already a problem. This is a problem in circulation. Anything about skin color, oxygen saturation, there is a problem with the circulation, guys. It simply means that there is now a problem in the oxygenation process. Only minimal amount of oxygen is able to reach the peripheral circulation, especially the fingertips, right? Or maybe the earlobes, or maybe the nose, when you're using those other pulse oximetry patches, because some others would have a chronic hypoxemia or hypoxia. So the digits will actually not gonna be a reliable site for checking the pulse oximetry. But for those patients, they need to have the pulse oximetry patch attached to the earlobe, okay, or maybe the nose, right, or maybe the forehead. Now, the reason for that is because it's closer to the central part of the body. It's not really the peripheral site. And so with this letter A, there is a problem in the circulation, okay? And so this is going to be a good indication that the patient is not getting enough oxygen, okay? So that is our answer. Why not letter B? The nose is red and swollen. Well, it could be, there could be some redness, or it could be some swelling that may indicate some inflammation. It's not life-threatening, guys. So we are going to eliminate the redness and swelling of the nose, okay? Again, it is associated probably with an infection, all right? But again, will this call for immediate action? I don't think so. It's not life-threatening. If we're gonna select letter C, the patient describes pain as 8 out of 10. Yeah, it is significant. It is severe pain. It requires, I meant the range. Okay. And so the severe pain is also significant. It will require prompt attention, but it's not as urgent as the hypoxia, okay? So we are gonna get rid of this. We can deal with this after we have dealt with the oxygen saturation, okay? Guys, for the Fahrenheit here, our cutoff is 100, okay? All right, anything above that, that is already considered a significant fever, okay? Just putting it simply like that. The temperature that is 100.2, that is already fever, and it suggests infection, Okay. Okay. Let me just take a look here. Message. Wait a second. Okay. Okay, guys. So when we are actually going to deal with the patient, most of us are going to have to measure our temperature, going to be in Celsius or centigrade. Okay. So that is actually around 37.9 degrees Celsius. So that is already above the cutoff because 37.8 is already considered as low grade fever or temperature. It's already fever. And so this is a good sign that the patient already has an infection, but this is it gonna call for an immediate action at this point? No, it doesn't. This is something that we can intervene after we have dealt with the we're going to have to address the high temperature, the 100.2. It's not really that high. It's not really that concerning, but it's worth to investigate further, right? It's not going to be, it's not going to require an immediate nursing action, as we should say, all right? And so, yeah, I've seen there's actually some hospitals in the US are using the centigrade, but majority of them are using the Fahrenheit. But it's really important that we know how to actually do the conversion as well. Okay, so that's going to be calculated, right? And so here, our issue is about the circulation. There is a drop in the oxygen level, and the patient is not wearing O2 at this point, room air. So this is going to be dealt with accordingly. What we're going to need to do is to make sure we are going to assess and intervene. Maybe we're going to have to start the O2 administration. And this is going to be challenging, guys, especially that the patient has nasal packing, okay? So they probably can benefit the use of the mask, all right? Not necessarily the nasal cannula because of the nasal packing. It is obstructed, right? It's packed because probably the patient had a nosebleed, or there could be a polyp that has been bleeding, and it's going, the packing is intended to apply pressure into that bleeder in order to prevent more hemorrhage, right? And I'm just gonna give you a good scenario actually. And I was working in one of the shifts, and I just finished getting the verbal report from the previous shift. So this is a patient that was a new admission, right? I was never told that the patient was gonna have a nosebleed because the chief complaint was never about the nosebleed. The patient came in because of a COPD, hypoxemia, right? And the patient was already wearing the nasal cannula at 1 liter, right? So I was just saying, hello, how are you doing? It was just my first round after getting the verbal report. So the patient was watching TV, so pleasant, so alert oriented. I was like, all right, I'll see you in a bit. I will just review the medical records and I will come by in about an hour or so. But when I left the room, 15 minutes later, the nurse secretary or the unit secretary alerted me, called my phone, telling me that the patient called. She wanted to see me because there's something going on with her. And so when I showed up into the room right away, yeah, she was bleeding in her nose. She has a major epistaxis. So to my surprise, I was like, what the hell happened to my patient? Well, yeah, nothing I can do but to apply the pressure right to the anterior portion of the nose. I had her tilt forward in order not to cause some obstruction into the airway. So it somewhat stopped the bleeding, but I've already seen her gown soaked in blood. That really creeped me out. It was like, no, it wasn't like this before I left the room. And so while I was applying the pressure, and I told her, can you just put your hand right on top or right into the nose bridge, right? So I had her pressure that. And good thing that we do computerized charting. And so I was looking into the chart real quick while I was like multitasking. It's like, okay, so this patient had a distant medical history of epistaxis. So there you go. I was like, oh, bummer. And well, I have to call the on-call physician, right? So notified right away, hey, I have this patient with a COP diagnosis here, hypoxemia, but we have a new issue. She is bleeding. She has epistaxis, and with an approximate blood loss, maybe about 50 mLs of blood, this is significant. And so he came right away inside the room, and he was looking for the nasal trumpet. So the nasal trumpet is actually one of those devices that will be inserted into the nasal cavity in order to pressure the bleeder. And so she had to wear that for the good 24-hour period. And yeah, we looked into her coagulation studies, INR, PT, clotting time, platelet count. Everything's just normal. So what really happened was that the patient was speaking into her nose and caused that erosion. It caught that bleeder. And so that's why she ended up bleeding. But anyhow, yeah, it was quite a surprise, but kind of funny experience. Yeah, so let's go back to the situation here. The nasal packing is intended to pressure that area where the bleeder is, okay? And again, the 88% saturation in room air is a big deal. This is a problem of what? Circulation. And the patient might end up with a respiratory compromise. So maybe the patient now has aspiration, okay? Possibly because of the nasal packing that was lodged into the upper airway, and it could have caused airway obstruction. So our oxygen saturation of 88 is a critical finding right now, okay? We need to intervene this patient right away. Okay, the rest of those manifestations are, yeah, I can deal with that in the next hour or so, or not really. 8 out of 10, yeah. Once I dealt with the 88%, giving them the oxygen, probably that will improve. Checking for the airway to see for the obstruction, we're gonna get rid of that. After that is dealt with, we're gonna address the patient's pain level, 8 out of 10. That is severe. So make sure that you take care of that patient's pain sensation. Moving to the next question right now. The nurse is managing a patient following a diagnosis of acute pharyngitis caused by Candida albicans, okay? Acute pharyngitis, all right? So this is going to, the nurse is managing a patient following a diagnosis of acute pharyngitis caused by Candida albicans. Which action should the nurse include in the care plan? So our issue here is acute pharyngitis caused by the Candida, which is a yeast infection. So what you should include in the care plan? Is it A, checking for any penicillin allergies? Or is it B, advise the patient to sleep in a warm and dry environment? Or is it C, refrain from offering the patient warm foods or beverages? Or D, instruct the patient to use the prescribed nystatin mouthwash with a swish and swallow method? Yeah, the sessions will remain active in the live tab of our YouTube channel. Okay. Yes. All right, so letter D, instruct the patient to use the prescribed nystatin mouthwash with a swish and swallow method. Have you done this to your patient when you had your clinicals? The nystatin is actually that medication that will require the patient to swish and swallow. Make sure that you're mixing the medication in that container because it's a suspension. You want to make sure that the drug is mixed well in order to do its therapeutic effect. Then you're going to have to instruct the patient to swish, have them swish in their mouth for a good 3 to 5 minutes to let it evenly spread into the oral cavity, and eventually it will be swallowed. Okay, so this is the correct answer for this question. We are going to administer or have them use the nystatin mouthwash, swish and swallow. And why it's supposed to be swallowed? Well, when they're doing that, it will at least allow coating of the medication into the back of their throat, right? And this will also provide some coverage into that infected area. Okay, so make sure that they practice this procedure correctly, or else they're not going to have get the therapeutic value of the medication. All right. What about letter A? Check the patient for any penicillin allergies. Well, the penicillin allergy really around this time is not going to be relevant, especially for treating the candida infections, because the candida is not going to respond to penicillin. Our microorganism is a fungal yeast infection. It's not going to respond to the penicillin. No. So we're going to have to eliminate this one. What about letter B? Advise the patient to sleep in a warm and dry environment. When they do that, it would be more appropriate for them to be in a room that is humidified. So there should be a cool mist humidifier. Make sure that the patient has enough humidification in that room. It will also relieve their sore throat. Humidifier. Okay. It will allow the mucosa to be moist. And so this is going to be a wrong option. Same thing with letter A. What about letter C? Refrain from offering the patient warm foods and beverages. Yeah. What do you think about here? Refrain from offering patient warm foods or beverages. This is incorrect. Not refrain, but actually you're going to encourage. Warm liquids can actually be comforting for them. It will alleviate the throat discomfort. So we are going to get rid of this option because of the word refrain. Okay, we should be offering them warm liquids to soothe the throat discomfort. Okay, so again, our testing strategy here is to make sure you review the appropriateness of the treatment. Make sure that you are going to understand what the problem is, and in our case it is acute pharyngitis caused by the Candida albicans. It will only respond to the nystatin medication, which is an antifungal. Okay, it will not respond to the penicillin. Okay, so there's no need for us to screen the patient for the penicillin. So again, our answer here is letter D. All right. Good job, guys. For those who answered letter D, wonderful. Let's take a look. Next question. To prevent aspiration in a high-risk patient, which action should the nurse implement? Is it A, turn on immobile patient at least every 2 hours? B, position a patient with impaired consciousness on their side? C, use a nasogastric tube to feed a patient with high caloric needs? D, watch for respiratory signs in an immunocompromised patient. All right, to prevent aspiration in a high-risk patient, which action should the nurse implement? Is it A, turn An immobile patient at least every 2 hours. Letter B, position a patient with impaired consciousness on their side. Or C, use a nasogastric tube to feed a patient with high caloric needs. D, watch for respiratory signs in an immunocompromised patient. All right, I'm seeing patients answering letter A. Bethany answered letter B. Mary Moyo answered B. Same with Mary Akuri, letter B. Okioma, B. Enjoys letter B. Wonderful. Okay, let's go through. Okay, let me just give the answer first thing here. So, our patient, it said here, to prevent aspiration. Okay, this is the concern in this scenario, to prevent aspiration in a high-risk patient. So basically, we're going to have to identify the nature, the characteristic of the patient that we have in the following options. Is it the patient in A? Is it the B or the C or the D patient? So we're going to have to take a look at their characteristics. So the correct answer here, immediately I will just give the answer so you will not get confused. So the correct answer here is letter B. Why? It said position a patient with impaired consciousness on their side. Why? The reason when they are unconscious, if they're not going to respond to you, even with a vigorous stimulation, you're probably applying the pressure to the sternocleidomastoid muscle, or let's say you're applying pressure to the nail bed, and if they're not responding, that's not a good sign. And if this patient is in the med-surg unit, no, the patient doesn't belong there. Your patient could possibly end up with aspiration pneumonia because they will not be able to manage their secretions in their mouth. Why? Because in the unconscious patient, their gag and cough reflexes are gone. Oh, there you go again. Cough reflexes, gag and cough reflexes are going to be absent. That is a major issue in an unconscious patient. Okay? That is a big issue. And as soon as you have this assessment finding in an unconscious patient, your priority here is airway patency. Always, never fail. Okay? Always worry about the patency of the airway. Again, why? It is because their gag reflex and the coughing reflexes are gone. They're absent. They will not be able to manage the salivary secretions. So they will still produce saliva even if they're unconscious. And if we are not going to intervene this, potentially the saliva can go into their airway, causing aspiration. That's a huge problem, guys. We don't want that. Now, so our answer here is letter B. Of course, nothing else. Position a patient with impaired consciousness on their side. Lateral position. Make sure that they're able to drain the salivary secretions, not going inside into the airway. Lateral position. Or side lying position in order to allow the drainage. But other than that, other than positioning them to the side, I want to make sure that there will be an oxygen setup. Make sure that you're checking for their saturation, and also get ready with the suction setup. It could be a Youngkower suction setup. You can do this easily with the Youngkower suction tip. You can suction it in the oral cavity every now and then to make sure that there is no accumulation of the saliva in the cheeks or the mouth. You have to do that. And what else? If the patient really is in this state, I would not feel safe keeping this patient in the med-surg unit. That is a huge issue, okay? For those patients that are not going to be able to contain or manage their secretions, they need frequent monitoring. And if you are in the med-surg unit that has 5 patients assignment, or let's say 8 or 7 in some states, no, this is not appropriate for this patient. You're gonna have to prioritize this patient, so it will demand more of your time. And so this is not appropriate in the med-surg setting. You need to talk to the medical provider. Hey, I'm not comfortable keeping this patient in our med-surg unit. He is not able to manage his secretions. I've been suctioning this patient for several times already in within an hour. I recommend this patient to be moved out from the med-surg, maybe to a higher level of care. That should be your script. How high do you want the head of bed with this position? For me, if the patient is unconscious, I would not feel safe to put them in an upright, right? They will not be able to support themselves if they are sitting upright. They're going to end up like to the sides, right? So 45 or 30 degrees angle, but they are repositioned to the side, not flat, not on their back, okay? So our priority here is to make sure that they are side lying, okay? Not on their back, in order to allow the drainage of the oral secretions. That is our role here, okay? Now, if we are going to answer letter A, let me get rid of my writings. If we answered, okay, let me just put here the correct answer so you don't get confused and asking for the same question. The correct answer is letter B. Now, if you had answered letter A, turn an immobile patient at least every 2 hours. Yeah, that is a good intervention. They're immobile. But does that address the airway of the patient? No. Because when you are just telling me that you are repositioning the patient at least every 2 hours, it's not telling me that they are positioned onto the left side. It's not giving me a picture if they are positioned to the back. No. And so this is not a correct answer. It could be a good intervention for those patients needing frequent position change, maybe because we are worried about their skin integrity. Maybe they are prone to skin breakdown. Yes, we can do this intervention. But if we are going to be asked about airway patency, this will not target that goal, okay? Let's take a look into letter C. Use a nasogastric tube, a patient to feed a patient with high caloric needs. Guys, tube feedings are actually one of those causes that could lead to aspiration risk. Okay, please take note of that. I'm not talking about that you should not be giving them the nasogastric tube feeding if needed. No, I'm not telling you that. I am telling you that there is an increased aspiration if they have tube feedings. The reason? Well, of course, when there is tube feeding, there's that presence of continuous, probably food in the stomach. And of course, with the presence of the tube, the sphincter is not totally closed. And so there will be a chance that the food contents will go back up into the esophagus. And of course, with the unconscious patient, when you are probably shifting their position, potentially there will be a backflow of the food contents into the esophagus and eventually going into the airway. Okay, so that is why there is higher risk of aspiration. But guys, like I've said, I'm not talking against the tube feeding. Tube feeding is actually one of the feeding modalities that we can use for the patient, but you have to be careful when administering the tube feeds. Now, letter D. Watch for respiratory signs in an immunocompromised patient. So yeah, this is going to be a good intervention to detect the manifestations of pneumonia, but it does not address the possible aspiration. It will not prevent, does not prevent aspiration risk. Aspiration. Okay. So that's the rationale why letter D is wrong. And again, guys, our correct answer is letter B. position the patient to their side because of that absent gag and cough reflex. Remember this, okay? Remember this. Now, what we need to do here again, your concern here is airway patency. That's huge. That is very huge. So don't neglect your patient that is unconscious. Hey, yeah, my patient is okay. He's in bed. He's not climbing out of bed. Yeah, they're not climbing out of bed, but look into the airway, okay? Oh, thank you, Ria. Now let's move on to the next question, guys. Question number 27. There's way too much more question here, so I don't know if we can end this. We can complete all the questions, but I'll try my best. The question states, an elderly patient aged 66 is hospitalized due to dehydration and altered mental status. He is receiving intravenous fluids for rehydration. The nurse, while checking his vital signs, observes that the patient has a high fever of 103, there's double Fahrenheit here, 103 Fahrenheit, which is closely equivalent to 39 degrees Celsius, a productive cough with yellow sputum, experiences chest pain that worsens with breathing. The nurse considers that the patient might have developed what? Again, the question is about an elderly patient aged 66 is hospitalized due to dehydration and altered mental status. He is receiving intravenous fluids for rehydration. The nurse, while checking his vital signs, observes that the patient has a high fever of 103 degrees Fahrenheit or 39.7 Celsius, a productive cough with yellow sputum, and experiences chest pain that worsens with breathing. The nurse considers that the patient might have developed A, acute respiratory distress syndrome, is it B, heart attack, is C, tuberculosis, D, pneumonia. Okay. All right. I want you to carefully check your answer. Okay. Make sure that you are recalling those concepts that I had taught you in my previous lectures. So I'm seeing a lot of D's here. Abby answered D. Franklin answered D. Bethany answered D. Mariama Masabara Nofane. I hope that I did not mispronounce her name. Chika D. Virtuous Lady also answered D. Melrose D. Yukuma D. And Joyce answered D as well. Very good. Yeah, this is quite easy to spot. So the correct answer for this is letter D, pneumonia. Okay. So why are we suspecting that the patient has pneumonia? Well, of course, the fever has that high fever, right? Because of that, let me list down the items here. Fever. Another is that the patient has what? The productive cough with yellow sputum. That's another element. Okay. What else? He complained of chest pain, worsens with breathing. So this is basically what we call as pleuritic chest pain. When the patient breathes in deep, this is referred to as the pleuritic chest pain. And this is not a good sign. The patient could be developing some form of a complication. I don't want them developing complications, but eventually they will have that. And so this is going to really fit that characteristic pneumonia, okay? The fever, the yellow sputum, and also the pleuritic chest pain. What else do we have? Did we miss anything here? Okay. Right. So these are the classic manifestations of our pneumonia. If we are going to select letter A, do you think it's really the acute respiratory distress syndrome? No, it isn't. The reason being is that the ARDS, acute respiratory distress syndrome, actually it is characterized by an abrupt shortness of breath. Abrupt, SOB, shortness of breath. And also low O2, okay? And this can progressively worsen if not treated. So pretty much like the same manifestation in a patient that may have severe case of COVID, that's pretty much ARDS. Yeah, that's pretty much it. The patient that has a severe COVID case actually will lead into ARDS. So I just want to give you that mental picture there. But it does not usually cause a productive cough during the acute phase. No, it doesn't. It doesn't normally cause them to develop high fever or those pleuritic chest pain. And so that's why the acute respiratory distress syndrome is going to be eliminated, because those the symptoms that we are describing here does not really fit into this patient with ARDS. No, it doesn't. Only it fits to this person with the pneumonia. Let's take a look about letter B, heart attack. No. When the patient has a myocardial infarction, usually what they're going to experience is the constant chest pain, which is not going to be influenced by the breathing or the coughing. And it does not really cause a fever or, let's say, a productive cough. That's why we are eliminating the heart attack. For letter C, tuberculosis, well, the TB, pulmonary TB, is going to be characterized by persistent cough. But often they're going to have that classic hemoptysis, okay? Not yellow sputum. That's why the tuberculosis option doesn't fit the bill, okay? Our correct answer here is pneumonia. So my strategy here for you guys is to recall the crucial clinical findings in the patient. Make sure that you recall those key features, especially for the pneumonia. Remember the key features for the ARDS. Remember the key features of a heart attack. Remember the key features of the tuberculosis, okay? Guys, I'm telling you right now, you got to go back to the fundamentals of nursing, the assessment, because this is where you're going to be killed if you're not aware about the crucial assessment findings. NCLEX will do that to you. So I highly encourage that you go back to the fundamentals of nursing. When you are reading the review book, focus into the assessment findings. It will help you a lot. Because if you are just focusing into the nursing action or the pathophysiology, sometimes the pathophysiology will just get you confused if you don't really just looking into the arrows, the diagrams. It might help you at some point, but getting yourself engrossed, if you're really going to really focus into the abnormal findings, this will eventually stick into your subconscious. Hey, this is the characteristic of this patient. So this is what I'm going to look for in the assessment findings. So that's my tip for you. Okay. Now let's move on to the next question here. Question number 28. A resident of a long-term care facility who has been on a continuous tube feedings now presents with a cough, producing tan-colored sputum and a fever of 104 degrees Fahrenheit, and also the 40 degrees Celsius, right? Upon listening to the client's lungs, the nurse detects bronchial breath sounds in the right middle lobe. The nurse suspects the patient may have developed. Okay, let's go back to the question. A resident of a long-term care facility who has been on the continuous tube feedings now presents with a cough producing tan-colored sputum and a fever of 104 Fahrenheit. Upon listening to the client's lungs, the nurse detects bronchial breath sounds in the right middle lobe. The nurse suspects the patient may have developed A, lung collapse, B, airway inflammation, C, pneumonia, D, blood clot in the lung. Okay? Take your pick. Thank you, virtuous lady. All right. All right. Wait for your answers here. Okay. Or maybe I can start answering right now. The correct answer for this question is what? The correct answer here is pneumonia. Yeah. So you will see here a same pattern. Okay. The fever, the what else? Cough producing tan-colored sputum or purulent sputum. Okay. And yeah, look at this situation right here. A resident of a long-term care facility who has been on continuous tube feedings. Yeah, remember what I said earlier about tube feedings? Yeah, it is one of those risks that could lead to the aspiration pneumonia. So our patient here has the classic pneumonia signs and symptoms. The productive cough that is tan-colored, the fever of 104, and also bronchial breath sounds in the right middle lobe. Okay, now let's go back to the assessment. So I have an avocado lungs here, a pair of avocados. So yeah, aspiration pneumonia. So here, when you are going to hear the bronchial breath sound in the right middle lobe, which is basically right here, that is an abnormal sound. You should not hear bronchial breath sound into the peripheral section or the middle lobe. Not a good sign. Bronchial BS. No, this is only considered normal. The bronchial breath sound is only considered normal when you're auscultating the major airway, the trachea, okay? But never in the right middle lobe or the right lower lobe or the left lung lobes. Never. When you're going to hear the bronchial breath sound, that simply means that there is now consolidation with the amount of fluid collecting in the middle lobe. It's allowing that tubular sound that is abnormal, okay? It should not be tubular. It should not be bronchial sound when you're auscultating this section. It will only be considered normal if you are auscultating right in the trachea, the major airway, but not in the middle lobe. This is a huge manifestation. So this is a red flag. We're going to have to, what do you call this? Associate that with the pneumonia, okay? Now, why not letter A, lung collapse? Well, when you have a patient that has a lung collapse, it is basically telling you that there is decreased breath sound, decreased BS. Let me just, okay, allow me to shorten here because I don't have enough space. Okay, decreased breath sound if we are talking about the lung collapse, which is basically the atelectasis, right? Okay. So what does that atelectasis really mean? Well, there is no adequate entry of the air that has been inhaled into the alveoli. You will not be able to hear that, okay? And so here, the patient will have the crackles because of the pneumonia, but lung collapse is not one of those, all right? It might be a complication, but for a patient that has a pneumonia, this is going to not a common occurrence, okay? This is going to, the pneumonia that we are talking about is more associated with the productive cough, okay? And also the fever. Increase mucous secretions, okay? Now, if we're talking about the airway inflammation, this pertains to the bronchitis, inflammation of the airway. So we're talking about the terminal bronchioles, the main stem bronchi right and left, and this is not really the classic manifestation because when we are talking about bronchitis, usually the bronchitis will present with a cough. It can be either productive or it could be non-productive, okay? But more often, with the sputum characteristic of the bronchitis will be clear, okay? Most often, the majority, it will be clear sputum. They will have increased sputum secretion, but it will be clear, not tan colored, which is characteristic of the pneumonia, okay? So the fever, the localized breath sounds are not really the characteristics for this, so it doesn't fit to the B as well. Now, talking about the blood clot in the lung, PE, pulmonary embolism. So what is this? Well, with the PE, it doesn't really cause a productive cough with a tan sputum. So let me clear this out here. Clear. With a pulmonary embolism, yeah, they can also produce some cough, but not really the tan type of sputum. No, not tan. Okay? And they are not usually going to develop high fever. No high fever. That is why we're going to eliminate that as well. So again, our correct answer here is letter C. So I'm trying to really present the pneumonia to you guys so it will kind of stick a little bit more to your subconscious. So again, our technique here, our strategy here is to make sure that you are focusing on the symptoms, the fever, the kind of sputum production, the bronchial breath sounds. This means that the patient now has accumulation of the mucus in the airways and also in the middle lobe, the right side. It can significantly narrow or it can definitely affect the airway as well, the exchange of gases. So let's move on to the next question right now. Question number 29. A 56-year-old male patient has a chest x-ray showing clear lungs, but a Mantoux test comes back positive with a 10 millimeter induration, whereas the previous test was negative. The nurse informs the patient that these results indicate that the patient A, had tuberculosis in the past but is no longer active, B, received treatment for TB successfully but skin tests remain possibly indefinitely, or C, is a seroconverter, meaning the TB bacteria have entered his bloodstream, or D, is a tuberculin converter, indicating he has contracted TB since the last skin test. All right. Again, the situation said a 56-year-old male patient has a chest x-ray showing clear lungs, but a Mantoux test comes back positive with a 10 millimeter induration, whereas the previous test was negative, and the nurse informs the patient that these results indicate the patient had tuberculosis in the past but is no longer active, B, received treatment for TB successfully, but skin tests remain positive indefinitely, and C, is a seroconverter, meaning the TB bacteria have entered his bloodstream, and D, is a tuberculin converter, indicating he has contracted TB since the last skin test. All right. Kidoki. I'm only seeing 3 of you guys. Mary Moyo answered C. Mary Curie A. Abby answered D, and Obey answered letter B. All right, so what is the correct answer here, guys? All right, the correct answer for this question is letter D. Is a tuberculin converter, indicating that he has contracted TB since the last skin test. Well, take a look into the situation here. It said that the patient has a chest x-ray showing clear lungs, which is good, right? Clear lungs is good. But it said here, Mantoux test comes back positive. Okay, so let me put here, this is a significant finding. The PPD skin test now is positive. and it stated that the induration is 10 millimeter. Okay, you really have to capture the size of the induration, guys, because it will vary. The interpretation of the skin testing will vary according to the size. Like I have mentioned in my lecture, you have to capture that size. So it said the patient is negative in a chest x-ray, but the PPD is now positive. Okay, we're going to look into the history here. The patient's previous test was negative, previous. But in the recent or the current time, the patient now has a positive 10 millimeter induration. Okay, so the correct answer for this question is letter D. Let me explain, okay, why the patient is what is referred to as the tuberculin converter. Okay, so what does this mean? A tuberculin converter is actually a person who developed, so a tuberculin converter rather is a person that had developed a positive reaction to the Mantoux test or the PPD. Okay, after, okay, we're not done yet, after a previously negative skin test. So I want you to really understand here that the term is only applicable to those patients that turned positive in the recent PPD, but they were previously negative. Okay, so this is what we call as tuberculin converter, which basically fits this scenario. Okay, so they were negative before, but now they have positive finding in their PPD. Why not letter A? Had tuberculosis TB in the past, but is no longer active. Okay, why is it wrong for letter A? Well, a past tuberculosis infection is no longer active, right? It would not necessarily result in a new positive skin test. Okay, all right? So that is why this is not going to fit to this scenario, because the patient was previously negative. But here, when it said had tuberculosis TB, that is wrong, because when the patient had TB in the past, they should have a positive induration already. Okay, did you get that? So we are eliminating letter A. What about letter B? Received treatment for TB successfully, but skin tests remain positive indefinitely. That is also wrong. Why? It's because if the patient had successfully been treated for TB infection, they can really leave a person with the positive. They will remain positive for their entire life. The positivity will be there, okay? But again, let's go back to the scenario. The patient had a negative skin test. So again, it's not going to perfectly fit the description that we talked about in the scenario. Okay, so again, it said receive treatment for TB successfully. So when you're gonna say treated with a treatment, he received a treatment in the past, so that simply means that he was positive, right, for TB, right? And so when they're positive, then the PPD in the previous reading should always be positive, not negative. So it's definitely a contradiction. So we are eliminating this one. Yeah. Sometimes they stay positive, only the chest x-ray proves negative. So I got confused. What about sit upright? I'm not quite sure with a sit upright. Maybe this is a late reply. But virtuous lady, were you able to follow really the explanation why the patient's negative skin test is a very significant, a previous negative skin test is going to be a huge factor in selecting the the option here, okay? And so let me go back here. Let me erase those. So to lessen the confusion. Okay, so here are the important data that we have. Previous test was negative. Recent testing shows in duration of 10 millimeter. So let me summarize this here. Past PPD was negative. If they're negative, then that means that there is no TB, right? Yeah, no TB. With the present PPD in the situation, it said that the patient is now positive in duration of 10. So this is now really a possibility that the patient probably has been exposed, right? So there is now possible exposure to tuberculosis. Now, we are actually wanting you to select. The nurse informs the patient that these results indicate the patient, okay? So if we are selecting letter A, to had tuberculosis in the past. Did the patient have tuberculosis in the past? Of course not. Their PPD was negative in the previous, right? So eliminating that one right away. Letter B, received treatment for TB successfully, but skin tests remained positive indefinitely. This is also wrong. Why would the patient receive a treatment when they were negative, right? That is also wrong. Seroconverter, A, is a seroconverter, meaning TB bacteria have entered their bloodstream. What does that mean? When we're talking about seroconversion, what does that mean? Seroconversion basically refers to the detection of the antibodies in the blood. Do we have that information that there is seroconversion? No, we don't. Okay. So we're not going to be able to apply this term into the scenario. So we are left with the only option, which is letter D, is a tuberculin converter, indicating that he has contracted TB since the last skin test. How is that? Is that clear enough? Okay. I want to hear your comments and I want to see your comments in the chat box. All right. So again, the previous negative skin test would really be a factor for you in selecting the option here, okay? So if you had selected AB, you're wrong because the negative PPD in the past simply means that he had no TB infection, all right? Let's move forward here with the next question, last question. When we're gonna end, we're gonna continue this tomorrow. Last question here. A 72-year-old male patient is experiencing severe shortness of breath at rest, appears thin, okay, and uses accessory muscles for breathing. He is breathing rapidly with a prolonged exhalation phase, has no cough. Yeah, it is a difficult question. That's why you have to read through the content there, the situation. So let me go back to the situation here. A 72-year-old male patient is experiencing severe shortness of breath at rest, appears thin, and uses accessory muscles for breathing. He is breathing rapidly with a prolonged exhalation phase, has no cough, and supports his chest by leaning forward with his arms and his knees. Yeah, leaning forward close to like tripod position, right? So the nurse believes that the patient might have, is it A, acute respiratory distress syndrome, or just simply ARDS? B, asthma, or C, chronic obstructive bronchitis, or emphysema. Okay. So what do you think? ARDS. I think I am needing some glucose in my brain because I'm missing some letters already. ARDS. Okay, I see your answers. Letter D. D. Okay, very good. That is the correct answer. And let me post the letter over here so you don't get confused, is the answer. Okay, D is the answer. And why? Well, with the symptoms that you are seeing here, hectic, thin. Okay, let me list down here the manifestations that are present in our scenario. Thin. What else? Use of accessory muscles. What else? We have rapid breathing. Okay, so I'm just going to put here increased respirations, increased RR. And then prolonged exhalation phase. Exhalation is prolonged. So that simply means that they are trying to get rid of the old air from their lungs, right? Increased exhalation. So you probably are thinking that, okay, my patient probably is doing the pursed lip breathing. Yeah, because it matches that characteristic. Pursed lip breathing, wherein they're going to inhale, but when they're exhaling, they're going to do the pursed lip, like. So when they're doing the pursed lip breathing, it will allow a much more prolonged exhalation to facilitate the exit of the old air, to allow the CO2 to leave the respiratory tract. Okay, so this is a very common, these are very common manifestations of emphysema. Okay, and of course, supports his chest by leaning forward. This is like a tripod position, really, with the arms on his knees. That is a tripod position. So these are common manifestations of a patient with emphysema. There is prolonged exhalation. There's also a lack of coughing. There's also going to be the use of the accessory muscles. They're also going to have increased respiratory rate. So these are the things that you need to look for in a patient with emphysema. Okay, why not letter A? Acute respiratory distress syndrome. Why not letter A? Well, again, I said earlier about the ARDS. The ARDS is going to be acute, rapid onset of SOB. Rapid, let me clear that. Rapid onset. Tripod position. So they're actually gonna like lean forward with the feet placed far from each other, and then they're gonna have to support themselves like in a leaning forward position, sitting position, but they're kind of leaning forward. This is what we call as the tripod position. And so that's why I'm talking about the ARDS right now. So please pay attention about the ARDS. So again, I said about the ARDS as rapid onset of SOB. Rapid onset of SOB. Shortness of breath. Okay. And this is going to definitely require immediate intervention. With ARDS, our patient will end up with intubation, guys. Yes, most of the time, intubation. So this is much more severe than the case that we're talking about, like the emphysema. So we are actually eliminating the ARDS right now, like I've said. And so the manifestations that we are talking about here are chronic, okay? These will occur over time, not just like 2 days before the admission or 3 days before the admission. These are chronic manifestations that you will be seeing in this patient with the emphysema, okay? This is just not like happening out of nowhere. No. And so these are chronic manifestations. So the ARDS will not fit this one. Chronic signs and symptoms. Okay, I'm talking about the thinness, the cachexia, the use of accessory muscles, increased respiration, and exhalation. So these are common in the patient with emphysema. Now, asthma. Why not asthma in this scenario? Well, asthma usually involves sudden episodes of severe shortness of breathing. So they also have that suddenness of the attack. And they're going to end up with a coughing. They're going to end up with wheezing. So we don't see the wheezing in this scenario. So asthma will be out of the picture. Okay, remove asthma because we don't see any wheezing here. And with the asthma, there's also a lack of cough. Okay, so that's why it doesn't fit to the description. And yeah, we are left up with what? Letter C, right? Why not letter C? Chronic obstructive bronchitis. Remember about the bronchitis, they are known as the persons that may have increased production of the mucus, right? In the bronchioles, terminal bronchioles, the bigger airways. And so what they're gonna be seeing is that they're gonna be appear bloated. Not thin, but they are going to be bloated, okay? And many will have that bluish tinge in their color. Let me erase this. Bluish tinge in their skin color. Bluish skin. And then they also have the bloated appearance. Okay. So this is a totally opposite manifestation in an emphysema, because when we are looking into emphysema, they are what we call as the pink puffer, right? Pink puffer. And they're gonna appear thin. And also with a lot of that effort, their metabolic rate will be higher this time. And so they're going to be malnourished. They will have, because of the increased bodily demands for the energy, most of these patients with the emphysema will appear thin, okay? So there is that what we call this possibility of a muscle wasting. And so this is the contrast between the two. Emphysema versus the bronchitis. Bluish skin for the chronic obstructive bronchitis, whereas in the emphysema, they're known to be pink puffer. Bloated for the chronic bronchitis, but they're going to appear thin for the emphysema. All right. So that's it for today. I still have more questions to finish here. I think I have a remainder of about 5 questions. It's already 3:20. And so we are going to end our session this time. Probably I'm going to have to insert the remainder of the test questions in the next chapter. And so we really thank you for your participation today, for answering the test questions. And I hope that you are able to really learn something from today's discussion, okay? We really need to make sure that you're critically using your brain this time, okay? Yes, critical thinking is a must. And again, my technique here is to use the elimination process, not looking for the answers right away. Because if you're looking for the answers, the more that you will get anxious. Oh, I can't find the answer for this. The mnemonics that I have used is not appearing in the choices. You will start to panic. And so that is why you really need to understand the pathophysiology, the assessment, how the disease is affecting the body, in order that you can plan, you can diagnose the patient properly. And did you notice, guys, that in most of the reviewers, the materials that we have don't even have the nursing diagnosis anymore. And that is something that I don't like with the NGN, because they're not really presenting the nursing diagnosis. And I think that most people will move away from studying the nursing diagnosis. And that scares me, because this is not emphasized with the new review systems. No, you don't normally see them anymore. And so don't neglect studying the nursing diagnosis of each disease processes, because this will actually help you determine what would be the adequate or appropriate nursing action to implement in this patient. Okay, so do not neglect that nursing diagnosis. Always incorporate that in the nursing process. Again, that is just my feedback, and I hope that this is going to be reinstated in most of the reviews, with the other review centers online maybe, or in the books, because I'm seeing that it's not being discussed more this time, and I'm scared about that. And I'm thinking that it could really affect the future nurses as well. And so I hope that they're going to change their reviews. And yeah, we'll try our best really to make sure that you will be learning a whole lot more. And again, I thank you for your time. Appreciate your participation today. And I'll see you again tomorrow. So stay tuned for more updates. Thank you so much for your attendance today, and I'll see you, and you take care. Bye.